are the key factors that we want to address? What is the main change in your treatment that it can impart? Rapidity. The treatment has to get faster. If we say we are using digitalization in any of our treatment approach, if your treatment is getting more slower, probably you won't be motivated enough to use that tool. Number two, it has to be very specific. Specificity. At the same time, accurate and predictable. Whichever tool we want to use with digitalization, they have to be very accurate, and as a private practitioner, I can say it has to be very much predictable. Then only you will have that faith of patient in you. You have to deliver on the terms which you dictate at the time of consultation. These are the three most commonly used words whenever you search about digitalization in dentistry. And look at this radiographs on the screen. What do you see? In the first OPG, how these implants have been placed? How many of you want to end up placing this sort of implants? There's nothing wrong, implant must have get osseointegrated, but is this a prosthetically viable method of placing implants? No. At the same time, if we observe the second OPG, you can see some periapical pathosis, an implant has been placed on top of it. This type of errors occur in routine day-to-day practice when we are either going with free hand or we are not even taking preoperative CBCT, which is now a very integral part of our entire digital dentistry circle. We cannot even imagine digital dentistry without CBCT now. To overcome this type of errors and to make your treatment more accurate, more predictable, there is one option which is called navigation in dentistry. Now we all are well versed with what is navigation. If I reach to Bhopal airport and I have to reach to Rishiraj Dental College, I will open up my Google Maps and I'll enter Rishiraj Dental College. It will show me, it will guide me, it will navigate me that in which direction I have to go, how many kilometers I have to travel, from where I have to take left turn and right turn. That is navigation is all about. In dentistry, when we want to impart navigation, there are a few fundamental questions which are being answered with use of navigation. So while treating the patient, I want to know that where is my anatomical target. For example, we want to place implant in mandibular first molar region. There is infraalveolar nerve going below that. And you want to make sure that you are at a proper distance of 2 to 3 millimeters away from the canal. How to do that? With navigation, you can check where is your anatomic target. If you are dealing with a calcified canal, endodontist, when we are having a case of calcified canal, we go inside the tooth 10 millimeter, 15 millimeter, and there's chance of perforation. There's a chance we'll end up losing that tooth. But if we really want to locate the canal, the anatomic target where actually the canal is lying, we have to go with navigation. How do I reach my target safely? So first we are marking our target. This is the point, this is the area where we want to reach. At the same time, now we have to decide that how we can traverse through that path very safely without any iatrogenic error, without any perforation, without any complication. So navigation will guide you, your instruments inside the mouth, going in the proper location. If we want to reach our target point very safely, we have to decide that where and how shall I position my instrument. Sometimes when we are going for implants, the angulations become very tricky. And if you really want to follow proper angulation, then navigation is the best thing. Normally we always say that with experience we learn. But if you want to reduce that curve of experience, if you want to climb that ladder of success faster, probably digitalization can be of some help. And last one, where am I or where my drill is? While I'm placing an implant or while I'm doing sinus lifting procedure, if I want to see where my drill is going, am I hitting the sinus lining? Am I slightly away from the sinus lining? Or I have already perforated, I'm inside the sinus? How will I come to know? Either your tactile sensation will help you for that, or digitalization, dynamic navigation will show you in real time where your drills are going inside your patient's mouth. To sum up in digital dentistry, there are three main tools which we can use in today's era. The first one is static navigation. Static navigation is all about 3D printing. Whenever we are having a 3D printed guide for any of the treatment, that is called static navigation. Second is dynamic navigation. We also call it semi-robotic dental treatment. Why semi-robotic? Because there are camera systems available. They will show you dynamically, just like a mobile GPS where your instruments are moving. But it is not fully robotic. Still, the final choice is in clinician's hand. You have to take it at proper angle. And the last one is the robotic navigation. If you have heard of Yomi's robot, now many of the United States universities have started working with Yomi's robot, and implant surgeries are going completely robotic. And definitely there is a big role played by artificial intelligence in all of these treatments. In this video, what you can see is the robotic arm. This is Yomi's robot. As a clinician, your role is to do proper treatment planning in this software. And then you take the hand of the robot to the proper position. It will follow predetermined trajectory and hit the bone at perfect angle. It will create your glide path for the drills, and you can complete entire implant placement along with this robotic arm. If you feel that what if my patient is going to move? If your patient's head is going to wobble, the robotic arm will also move along with it. FDA has already given clearance to the system, and it is very safe to use into patient's mouth. With help of virtual reality, even in endodontics, when we start our journey in the preclinical time, we can see that how to enhance or enlarge the root canals, how to place eroters at the proper angle. If you want to do episectomy, at which angle you should be going so that proper root and dissection can happen. Everything can be achieved if you try incorporating virtual reality into it. This is a video from Jim Morita. They have developed a good virtual reality for endodontics now. And here you can see the first robotic implant placement done in year 2017-18. The first robotic implant placement which was done in China. And this successful robotic surgery was carried out with the same camera system that we use for semi-robotic surgery. Okay, it is only the upgrade in the hardware which is going to enable robots to place implant. See, but when I talk about robots, doesn't mean we are living in age of Terminator. Okay, still the final decision always lies in operator's hand, because you are the one who are going to decide what the treatment plan will be. If your basic concepts are clear, if you know that what inter-implant distance is needed, if you know what type of occlusion your patient have and you want to deliver, then only these treatments will make some sense. There is always a saying that even if a good tool is given in fool's hand, you can't achieve good results. So if you want to learn and start your journey with digitalization, it is very important that at this point of time where you are pursuing your undergraduation or post-graduation, you clear your basics, and along with that, you learn how digitalization actually works. So that's why we call it brain-guided surgery. It is not a fight between whether static navigation has to be applied or dynamic navigation. But most important is a clinician's brain has to be applied. You need to be thorough with your basics, and then only you can decide which type of treatment you can deliver. And here is one article which says guided implant surgery, making sure dental implants are safe, predictable and efficient. This is one of the first articles which started the journey of 3D printing in implantology. What happens in conventional implant surgery? A patient comes to you, you advise CBCT to the patient, you do the proper treatment planning on that CBCT, you decide whether you want to go for all on 4, all on 6, if 1 or 2 teeth are missing, you decide that what is going to be the angulation, and then you go freehand, place that implant, wait for 3 months, 6 months for osseointegration. Following that, you take impression and make a crown. People who are dealing with implants day in and out will realize that placing implant is not so difficult, but difficult is to rehabilitate the same patient with good processes, giving good occlusion. And that's why from the conventional implant surgery or the placement, now we are going towards prosthetic implant placement. First you plan your processes. You decide which type of processes you want to deliver, and then you place implant accordingly. When we go for 3D printing, this type of templates are made. We can call them surgical stent, surgical guide. It can be computer guided surgery or flapless surgery. There are many names for this treatment option, but the gist lies in that this is a static navigation, where you are creating a 3D printed model and then try to place implant along with it. In such cases, first you do clinical examination. You take CBCT, but at the same time you plan the processes, and based on that processes, you are going to place the implant. So what is the main advantage of doing that? The main advantage of doing that is that it gives you proper orientation. You sometimes save your cost on angulated abutments or many of the hiccups that we go through during prosthetic phase. Now, whether it is static navigation or dynamic navigation, it is very important to understand this basic slide. What is the main difference between the freehand treatment and guided surgery? Whenever we are going with the freehand treatment, your drill can go into multiple trajectories. There is a chance that if bone is thin, your drill can go on the buccal side or the lingual side. You may perforate a plate, or on one of the side, proper bone coverage is not present at the end of the surgery. If you want to make it more predictable, if you want to make sure that your drills are going only in one trajectory, then only guided flapless surgery is going to be of some help. So essentially, what is a guide? Guide is just a transfer tool. You are taking a software. On software, you take CBCT of the patient, impression of the patient, and make a design. Any design, when you want to transfer from software to patient's mouth, you need a transfer tool. And that transfer tool for you is surgical guide. There are different types of surgical guides being fabricated. Few guides are just for the pilot files. Few are having good support from the natural teeth. Few guides are taking support from the soft tissues as well. They are mucosa supported. And many a times we fabricate bone supported guides. That's how the final implant placement looks like while using 3D printed guides. But important part to remember is that there are different refines which have been developed for this type of surgical guides. Is there anything which I'm missing in the last 3 rows? So this is the refine which is having a stopper over there. What is that stopper? So when you are having a guide, and guide has proper thickness, the thickness has to be compensated with increase in the height of the stopper, so that your drill is going only at one position. But at the same time, if the patient is having less interocclusal distance, there can be some issue with it. There are a few myths around guided treatments as well. The first myth that not only we have to address is that guided surgery is not an easier way, it is just more accurate way. I would just like to add, it is easier way as well. It is not always difficult to do a guided surgery. It is accurate but easy as well. Second myth, that it is primarily indicated for more challenging cases. It's always up to a clinician whether you want to develop a particular digital workflow or you just want to select it for particular cases. We always say if you make it a part of your routine, then even a case where you just have to place 2 implants, you will still opt guided surgery. Because it will make a prosthetic part so much easier. If you want to go for immediate temporization following your implant positioning, guided surgery will make it much more predictable. The most important part is that it reduces the journey from novice to adept. Now what is novice? When a postgraduate student starts his journey in Department of Prosthodontics and Implantology, you are called novice because you are still at the beginning of your talent. At the same time, if you have a clinician who is practicing implantology for last 10 years, 15 years, how can you match the skills of so much experienced implantologist? That can only be achieved only with help of digitalization. It will help you to reduce that curve. Look at this case, where a single implant has been placed in the 4th quadrant. Looks like a very easy case, right? Single implant, we don't even need to go guided. We can place the free hand implant, yes or no? Looks easy case. But now look at the CBCT. What do you think? When we are going in the mandibular posterior region, there is a lingual fossa defect which happens. The bone is very thin on the lingual part. And in this type of cases, it is very important to go guided because you will get only one shot to put your implant into proper position. So these are the cases which may look easy at the first glance, but still they require digital intervention. still you need to go for guided surgery to make them more predictable and safe for a patient. At the same time, let's talk about endodontics. Now in endodontics is always a big issue around the small tissue. We are always dealing with the pulp and periapical disease, pain that patient gets. Isthmus areas where still there are pulpal tissues, there are calcified cases, retreatment cases, and sometimes endodontic surgery as well. How can a digitalization or a guided treatment be imparted or be used into endodontic treatments? In 2020 December, we published a book with Springer Publishing called Guided Endodontics. This book was labor of 3 years and a team of 15 endodontists and oral radiologists across the world. And we put up the first scientific book, how to use digitalization in endodontics and how to use it. Not only non-surgical cases, but also the surgical case. This guy is Dr. Stephen Cohen. As a postgraduate student, we always read only 2 books most of the times, Cohen and Engel. This is the guy who wrote forewords for the book. And I would just like to quote his words. It will be hard for some seasoned clinician to adopt this technology because they are too invested in more conventional way of diagnosing and treatment planning. But if we look back in the rearview mirror, we would see how many clinicians struggle to let go of X-ray film and adopt digital X-ray imaging. Ultimately, those dentists did embrace digital X-ray technology. The same holds true for 3D guided endodontics. It is not whether a clinician will adopt or not. It is only a matter of when. It is only a matter of time that you start using digitalization for even endodontics as well. As academician, if you look at just the number of publications we started in 2015 and now in 2022, the graph is going higher and higher. Every year there are more number of researches which are incorporated. First, let's start with static navigation. Because if I want you to understand dynamic navigation, it is important first to tell you how static navigation works, and then only we can advance to dynamic one. So here you can see a 3D printed model and a guide for lower anteriors having calcified canal. This is the final guide with the metallic sleeves. How to start, how the journey begins, whether you want to go for endodontic treatment or implantology, the first step is always taking a CBCT of the patient. When you take a CBCT, it will form a DICOM data and a DICOM file. After that, you have to take impression of the patient. When we are taking impression, it will form STL file. If you are taking conventional putty impression, alginate impression, you can always create a model, your laboratory will scan it, and that scan will create STL file. And after that, you go to a software. There are many softwares available online, and you have to merge that. Here is a study which shows the comparative evaluation between intraoral and extraoral scanners. I'm not going into depth of that, but you know intraoral scanners, if used properly, they are much more accurate. Yes, there are still few hiccups in scanning of edentulous arches, but with experience even you can crack that as well. Now, when I talk about softwares, there are many free softwares. So as a postgraduate student, you can just go online, download DentiQ or Blue Sky Bio. These are the free softwares. You don't have to invest a single penny to start your journey with digitalization. When you download the software, there are 2 options. First, you have to import the DICOM data. Then you can take the STL file, which is impression of the patient, and you try and play around with the software and plan at which angle you want to place implant, what is the depth that you can achieve in that area, what is the distance from the maxillary sinus or the intraocular nerve. That is the superimposition of DICOM and STL file. And once you have achieved that, before you go to 3D printing, you still need to double check whether superimposition is proper or there are some errors in superimposition. In this particular case, we are planning a guide for endodontic treatment. In implant treatment, if your planning is slightly here and there, probably your angle will be altered, but still you can place implant. In endodontics, if your planning is problematic, you will end up doing a perforation and you won't be even able to save the tooth. So that is a calcified tooth. If you can see tooth number 2, 1 and 1, 1, both looks calcified. You have to select 3 points on the STL file and same 3 points on the DICOM file. That means if you want to select the cervical third of the first canine, tooth number 1, 3, correlate with the 1, 3 on the CBC. That's how you take 3 points and the software automatically superimpose this data. Why this step is important? Because most of the times we are dependent on our oral radiologist to do the planning for us. And then we always complain that something is wrong, doc. The guide is not placing properly. I did guided treatment, but still my implants are going in different direction. Because you always have to ask your radiologist before they print your 3D guides that what is the exact angulation. Just show me how superimposition is done and what is your planning part. Here you can see the proper soft tissue superimposition. So this is the DICOM data, and when it is enveloped by a yellow color or purple color, it depends on the software, that shows that the DICOM data is encapsulated with the soft tissue around it. And if this superimposition is proper, then only you can achieve desirable results. The software always allow you to do different type of planning, either you are doing for endodontic or for implantology, and following that, either you can send the file directly to your 3D printer, and if you are not having 3D printer, you can send it to your lab, or a person you can outsource this via emails. Now, guided approach, there are a few prerequisites. Dr. Jaju is going to take a session about CBCT and endodontics, so I am not going to dive into this topic, but there are 3 points that I want everyone to remember. There are different FOBs for CBCT. If you want to go for zygomatic implant, you cannot work with the small FOB. You need the largest FOB available. If you want to go for endodontic part, you want to localize the root canal, then the smallest FOB possible has to be taken. So you need to guide and you need to write a prescription to your radiologist that which sort of CBCT you want, for which purpose you want the CBCT. For endodontic purpose, the smallest FOB possible. For zygomatic, the broader one. The resolution is very important. When you are going for endodontic CBCT, make sure that your radiologist is taking a CBCT with high definition on. Then only you can see very minor structures. Another important part, whether you go for implant or endo, the CBCT has to be taken with open mouth. Now, what is open mouth CBCT? The teeth of the patient while taking CBCT should not be touching each other. Now, the common thing people say, there is a bite plate. The patient has to bite on that and then CBCT will be taken. It will be open mouth. But that's not how it actually happens. If there is a bite plate, still many a times patients' posterior teeth are touching each other. And all the softwares that I mentioned, DentiQ, Blue Sky Bio, or you work with Navident dynamic navigation system, it won't be activated if upper and lower teeth are touching each other. There has to be proper spacing, interocclusal distance, even in the DICOM data. Then only software will work around it very efficiently. If I want to do a guided treatment for tooth number 2-1, can I work with this CBCT? Jago Bharat. What is wrong with this CBCT? I can say contrast is not proper, the resolution is not something that we can work with. Now, this CBCT was taken at one of the most reputed dental colleges of India, where I went for a life surgery. Okay? In Delhi. So my point of saying is that many times when we go to smaller towns or tier 2 cities, people feel that hum thode piche reh gaye digitalization. Metro cities are doing better. But I just like to highlight that each and everyone, we all are at the same level. Everyone is starting their journey with digitalization. If you go to all the reputed colleges, whether it is Savita Dental College, AB Shetty Dental College, AIMS Dental College, everywhere, still everyone is starting their journey with digitalization. We are not still far behind. We just need to know the basics. Even mistakes happen over there as well. And then you can get a CBCT which is having good contrast and good resolution, and then you can work with it. Why I am emphasizing so much on CBCT? यार lecture में तो बोला था dynamic navigation पे, ये क्या बोल रहा है? Because whichever technology you want to work with, it is always image-based navigation. There are different types of navigation. In dentistry, what we are using is image-based navigation. Your image is going to guide you. So if there is error in your CBCT, if there is motion artifact, let's say patient moved while taking a CBCT, do you think your treatment will be as accurate as you plan it on a software? It's not going to be. Even a small motion artifact, patient हिल गया CBCT के time पे, that can ruin entire journey of guided surgery. And only that's why we are spending first 15 minutes of the lecture just emphasizing on on these topics. So that's the main difference in the CBCT, which you should always observe and ask your technician or radiologist to repeat the CBCT if you need. See the contrast difference and the clarity that we can get. And the coronal third root canals are seen in each and every tooth apart from tooth number 2-1 and 2-2. You can see there is calcification present already. There are different type of drills which are used for that. First, normally on the CBCT, if it is for endodontic purpose, we try to trace the canal. If it is for implantology purpose, we go through the different sections and see what is the bone thickness present. Following that, we decide the target point. Now you need to decide at what target you want to place implant or you want to do your access opening. If the root canal is calcified up to middle third, then middle third, if it is 15 millimeter from the incisal edge, will become your target point. If you want to place an implant and your implant size you have decided is 5 by 10, 5 mm diameter, 10 mm depth, then 10 mm depth will become your target point. You need to decide two more things. The first one is what is the entrance point? From which angle you want to penetrate bone or you want to penetrate the tooth? And which drill diameters you will be using for the same purpose. So here you can see the target point was identified at 14 millimeter. And then you can try and negotiate the calcified canal. Now deciding entrance point, ठीक है, implant के लिए angle में पता चलेगा, endo के लिए क्या फर्क पड़ता है. But in endo, it is also important that you can't do access opening always from the incisal edge, as you can see in the first image. You have to go slightly on the palatal side so that you don't end up compromising the aesthetics of the tooth. Very minor points, but very important, because what is new with digitalization? We are not doing any extraordinary new treatments, but rather we are doing our ordinary treatments extraordinary. We are trying to improvise on what you are doing day in and out. But how to do it more accurately, more predictably, that's what we are playing with. With 3D printing, there are a few metallic sleeves which are used. They are either handheld or they are fitted into the guide. And there are two main factors that you have to always remember. One is the offset. Offset is what is the distance actually, the clearance between the guide and the tooth. That is called offset. Because if the clearance is less, it will be very snugly fitted. That means if patient is having periodontally compromised lower anteriors, you put a guide, and while you remove the guide, there will be extraction. It should not be snugly fitting. There should be some clearance. So that is the offset. And wall thickness. When you start your journey with 3D printing, you realize if the thickness of guide is not proper, while placing the trephine, your guide can also crack. It can break into multiple pieces. So for that, minimum thickness of 3.5 mm has to be imparted. Here is another case of central incisor which has been dealt with navigation. This is a static navigation. You decide what is the entrance point, from which angle you want to enter. And here is a slide which shows you that how on CBCT you can play around. And in different sections you can analyze root canal anatomy, you can analyze what is the bone level and the proximity to very vital important structures. Now there is something called selective retreatment. In endodontics, many times we deal with a failed dentition or a failed tooth. And when we want to make sure that there is pathosis just related to the one of the roots, you don't need to remove gutta percha from all other canals. You can just hit that one tooth, one canal, and do the treatment. That is called selective retreatment. For selective retreatment, the guided approach has been taken many times. If you observe this CBCT in front of you, you can see that the palatal canal has not been filled. It is a calcified tooth. And in this case, if you hit it with navigation, with guided approach, there are chances of success. I'll just play a small video. Here we are applying a static threading guide for the posterior tail. Just observe this video very carefully. If there are any mistakes, please pay attention. देखा कुछ इतना ही था video. We'll play again in slow motion. What did you notice? Guide is not stable. It is moving slightly. If you press it vertically, it is shaking. Can you see any of the water coming out? Can you see any coolant? Whether any coolant has been used or not? So guide was not stable. There was no water cooling. And that is the problem with regular static surgery. Number one, if your guide is not fitting properly, if fitting is an issue, you will end up doing a different type of treatment, which was not planned. There will be big error. Number two, water coolants are normally not used. And when water coolants are not used, even for implantology, what will happen? Bone necrosis. Too much heat will lead to damage to the bone. And the same will happen during root canal treatments as well. In this slide, I just want to highlight that when you even take the impression, we talk about STL5. This is the impression tray. We have placed impression tray and just showing you that normal impression tray will not go up to the depth of the vestibule. Many times you need to even modify your impression tray to take the deeper impression to create proper STL5. So you can use intraoral scans for that. Here is a case where we have done surgery, episectomy. You can find this type of cases over here. Now I would just like to highlight what are the drawbacks. What have you seen in the last 20 minutes? What are the limitations with this type of technology? It is definitely accurate. It can help you to do some cases. But you should be knowing where we can go wrong or what are the limitations. The first one, the patient is not having good interocclusal distance. The patient is not having good wide mouth opening. You cannot use 3D printed guides because a guide will have proper thickness, if you remember, 3.5 to 4 mm. A different type of drill which has to be used. So it's not the normal drill which you are going to use. You are going to use a longer drill. That means if patient has limited mouth opening, you cannot treat beyond first premolar. Number two, no guide will work with the high speed handpiece. You have to use always slow speed handpiece or piezo dispenser. If you start using your aerotor at 2 lakh to 5 lakh RPM speed, what will happen? There will be friction, patient will be able to see Diwali in his mouth. When your drill is going to touch the metal, there will be fireworks. It is time consuming, slightly. Why? Because you are dependent on someone else to plan your case. You are dependent on someone else to 3D print it for you. And most important, how many of you actually know that this 3D printed guide cannot be used directly into patient's mouth? Because it has to be disinfected. We are talking about implant surgery. We are talking about osteotomy guides. And what happens? Many times that happens, we have seen even in our own friend circles that LA has been administered, flap has been raised, and still you are waiting for your radiologist to deliver the 3D printed guide. And then he delivers guide with courier guy, and you directly place it in patient's mouth. And that's where we are incorporating another microorganisms inside that flap. To avoid that, if you want to use this technology, you should have your guide in your hands 24 hours before the surgery. And these guides are heat sensitive. You cannot autoclave them. You have to immerse that into disinfecting solution for 20 to 24 hours. And these are the recent developments I'm talking about. Within this last year, 2022, there have been research articles on it. It is expensive because if you want to do osteotomy and you want to place different implant, you will need two guides. The first guide for osteotomy and the second guide for implants. But the most important as a clinician for me is that it does not allow any changes in my treatment plans. On software, I decided that I want to place an implant at depth of 11.5 mm. But when actually clinically I'm going at 11.5 mm, I'm getting a very soft bone. I still want to go further inside. Sometimes I just want to stop at 10 mm. I feel at 10 mm that bone is good enough. I don't need to go further. How can I make that treatment plan change? This static navigation does not allow any change in this treatment plan, and that's why it is static. If you want to make any treatment plan changes, you have to be dynamic. So I started in 2015 with the static navigation, and 2018 we introduced to work with the dynamic navigation into our practice. This is how both looks like. The first one, the 3D printed guide, and the second one, a semi-robotic arm. This is a Navident dynamic navigation device that you can see. Now that is a laptop, and that laptop is having some software. So you don't need to have a third-party software. That is inbuilt software on which you can feed your CBCT data, you can do all the treatment plannings, and you can see in real time where your drills are moving. And this software is connected to this camera system. What you can see over here, can you see the two eyes over here? 1 and 2. These are called micron tracker cameras. Micron tracker is a camera which has been used for the last 25 years in field of neurosurgery. Whenever neurosurgeons are doing some complicated surgeries, they want to go inside the skull at a particular point. They want very accurate treatment plans. They don't want to damage any of the nerves. They know exactly where the target point is. And for that, this micron tracker has been used extensively. Now it is being used in dentistry, and what you can see over here is a light source. Because every camera gets affected by the type of light and the light temperature it gets. When you are taking your photograph for Insta, you know, right? Good lighting is important. Same way, for navigation, good lighting is important. The only difference is, there is a particular color temperature, which is 6K, completely white lights. That's what we need for proper activation of the cameras. Dynamic navigation actually works on the basis of triangulation. Now what is triangulation? When I talked about GPS at start of my session. How does GPS work? How does GPS know that what is my current location? Because there are satellites flying in the orbit. With those satellites, there will be a triangulation which will be created, and it will pinpoint my position right now where I am moving. The same will happen with this technology. There are two cameras that you saw. There has to be one tracker on your handpiece. Which your handpiece you are using, slow speed, high piece. And there has to be one tracker on patient's jaw. Do you understand that? Is everyone with me? Yes, sir. 3 points. The first one is the camera. Second, a tracker which is on the patient, either maxillary arch or mandibular arch. And third is my hand, which is having a handpiece. A tracker has been attached. And when this triangle is completed, continuously you can see navigation wherever drills are moving inside patient's mouth. The biggest advantage of using dynamic navigation is that it can show you real-time navigation. Real-time without any delay. If my ball burnisher is going on the buccal aspect of central incisor, it will show on the buccal aspect. If I move towards palatal side, it will move along with me on the palatal side. There has been one research article which states that accuracy of dynamic navigation compared to static surgical guide. And the results are really interesting. The results show that implant site do not influence the accuracy of dynamic navigation. Whether you are dealing with the central incisor or you are dealing with the last molar. If you want to do even third molar disinfection, osteotomy with this device, it will be as accurate as it can be for the central incisor. Accuracy of dynamic navigation is definitely higher than the static guide. But for me, this is the most important result of this study. Experience level of the surgeon do not affect accuracy of dynamic navigation. And that's what I've been talking about today, novice and experienced surgeon. As a beginner, if you want to have a good hand, if you want to do predictable surgeries with this type of technology, you can never go wrong. So here you can see that in a software, implant has been planned. This is the Navident planning software on which implant planning has been done. And now can you see this blue dot moving over here? Blue dot, blue dot. There are different angles, and when we are moving our instrument inside patient's mouth, it is moving on your screen. So you can see anatomically that instrument is on the occlusal surface of the premolar. Now it is on the distal part of the premolar. Then you start drilling inside. So you can see in real time that the green color drill is exactly going up to what depth, what angle. Are we going at the right angle? Yes. And here you can see what depth you are achieving. So the beauty of real-time navigation is that you can see all the CBCT section. As a clinician, two sections are important for you while you are placing implant. Buccopalatal view and mesiodistal view. Agree? What if you can see actually that where your drill is moving in the buccopalatal section and the mesiodistal section in the real time. We can even place good zygomatic implants with this type of option. We have also tried the same in field of endodontics. Here you can see that for a gastric canal, treatment has been planned. You can see the yellow color, which is a planned trajectory, and the green color is our long neck drill, which is going inside patient's mouth, and you can see exactly up to what depth and what angle we are going. It is not only working for implants, but even for endodontics, we try to utilize it. And at the same time, we are not compromising on the basic fundamentals of endodontics, which is rubber dam application, isolation. You can still achieve that and do the treatment accurately. So main advantage is that you don't need any specific instrument for that. If being implantologist, you are using your Austin kit or you want Dentium or Straumann or Nobel, it is open to any sort of system. You can use any implant kit. If you want to use your sinus lifting kit of any particular company, you can use that. If you want to use your Densa burrs, still it is compatible. Any of the drill or the burr, and you can directly start working with it. High-speed burrs and drills can be used with it. So it's not only that you can use your aerotor micromotor. Even you can use your ultrasonic handpiece. If you are into piezo surgeries, you are having your piezoelectric unit for the bone cutting, you can use it along with this system. There is no need of 3D printed guides anymore. And at the same time, in one axle, you can have multiple drill parts. If you are planning 4 implants or 8 implants, you can plan everything in the one DICOM data and start drilling right away. And the most important, it will allow you change in the treatment plan. You can change your treatment plan, you can change your angle within a second and it will start tracking in that direction. Now, the advantages, the main advantage is that it is very immediate, it is always chairside available. If patient comes to you with DICOM data, patient has gone to some other clinician for the first appointment and consultation. That doctor just advised a CBCT. And now patient is coming to you with the same CBCT file. You can directly start working on it and place implant within the next 30 minutes. You don't need anything else. Irrigation is also not an issue because you are using your regular handpieces. So there will be no chance of any error. Now the main fundamental heart of dynamic navigation. अगर मैंने इतना बोर नहीं किया और जग रहे हैं पीछे वालों, please remember these 3 terminologies. These are very important. Calibration, registration and tracking. For the static navigation, we decided that you take CBCT data, DICOM data on a software you superimpose, right? The same you are going to do with the software, with Navident, but it is very important to register patient's mouth on CBCT. With Navident, you do not need to take intraoral scan or impression all the time. You can just take CBCT and try to correlate CBCT with patient's mouth. That means, if clinically there is a carious tooth, you take a CBCT and now you have to correlate that. That means you need to teach software that DICOM data is having this broken tooth and clinically this one is the broken tooth. And how to do that? That is the process of registration. So, to register patient's mouth with the DICOM data, we need some tracker which can be placed on patient. Here what you can see, this fancy device, what you can see over here, that is a maxillary tracker. So we make our patient wear this one. So camera can identify that we are walking on the maxillary arch. If patient is going to move, this will move along with patient's head. And camera will identify in which direction patient is moving. So this is the maxillary tracker. If you observe carefully, it is taking support from the back of the ear as well. So it is very solid area. Even if a patient moves, there will be no error in that. These are the mandibular trackers which can be attached to the lower arch. This can also be used for maxillary arch. Okay. And there is one small device available which is called calibrator. So it will calibrate every device that you are going to use. You want to use high-speed handpiece, you have to put it in the number 4 and it will start working with it. If you want to use your round burr, you can use it. If you want to use your trephine for osteotomy, you can use it right away. You have to calibrate with the calibrator first. And that's how the registration looks like. When we are selecting 3 to 6 landmarks for static navigation, what were we doing? We are selecting 3 landmarks on DICOM and STL5. For dynamic navigation, we are going to select 3 landmarks on DICOM data and 3 landmarks inside patient's mouth. So now I'll be moving my ball burnisher on the maxillary central incisor. At the same time, the computer, the software, will record it on the DICOM data central incisor. And it will not record only one point, it will take different 100 marking for each tooth. So if you are taking 3 teeth, it will be taking 300 points. And that's how accurate the superimposition will become. So here you can see the numbers are going from 1 to 100, 1 to 100, that's how quick it is. If you actually start counting this process, it is 15 seconds for one tooth. Entire registration can be completed within a minute. If it's a very difficult case and you want to superimpose STL file as well, you can do that. It is not mandatory to use it, it is optional. So you can always superimpose your DICOM and STL file and trace registration. Now the calibration part. We need to calibrate our piezo dispenser handpiece, or micromotor, or aerotor burrs, and with calibrator there are different points on which you can get it registered. All the pointed surface area, if you are doing your implant placement, the first drill that you want to use is your lens drill. Following lens drill, you go with 2 by 10, 2 by 11.5, whichever drill you want to use. Each and every drill has to be calibrated. Now the first question that we get asked during live demonstration is that, Doc, my implant size is 5 by 10. I am going to use total 8 drills inside patient's mouth. So do I need to calibrate each and every drill for implant placement? Answer is yes and no. Ideally, you need to calibrate each and every drill, but being Indian, we always have our ways of working around with technology. You can skip one drill in between and still camera is going to follow that. And the last one, it will start tracking. If you are doing that, the tracking will be immediate and you can see in which direction you are going. Here we are just showing again what is mandibular tracker, how it can be attached. It is available in very different types. Sometimes they are available as a bite block as well. You can just take a bite registration paste, ask your patient to bite on it. You don't need even a cement to screw it on. The difficulty comes when you have completely edentulous patient. We talk about trace registration. That means you are moving your instrument inside patient's mouth. But what if no teeth are present? Your patient is completely edentulous. What are we going to do? In such cases, you need to place the bone screw, and on those bone screw, we start doing our trace registration. So here you can see, if you observe in the left bottom of the screen, a screw has been placed and a CBCT has been taken, and here the trace registration is going from 1 to 100, and it is recording different 100 points for this particular arch. So what is better for us? A freehand treatment, static navigation, dynamic navigation, but as I mentioned, it is always a brain-guided surgery what we are doing. So as a clinician, you need to decide that how many number of implants are needed for this case. What inter-implant distance you want to place. What is the distance that you want to create between the implant and the critical structure, which can be nerve or sinus. And the software will follow it. And here we are showing that how different type of drills and different type of handpieces can be calibrated with this system. Whether it is straight or contra angle, you can use it. Here is a case of episectomy, but what we want to highlight is the different view. When you look at this type of screen, what you should be looking. On the left top area, it is a camera showing you live surgery. So, medico-legally you are always secure. Your entire surgery is getting recorded in your laptop or your iCloud. This one is the OPG view, in which you can see entire arch. This is the target view. In target view, you have to orient your drill in the center of bullseye. If you hit this bullseye, you are going on the plant trajectory. Other two views are very important. First one is bucco-palatal view and second is mesiodistal view. Is everyone clear with these views? At least pay attention on bucco-palatal and mesiodistal view. So when you can see the screen in next couple of videos, you can correlate that what you are actually going to look at. And before that, when we go for implants, there are 3 terminologies. When we want to check the accuracy of a guided treatment, there can be coronal deviation, there can be apical deviation, and there can be angular deviation. That's what we are going to deal with. So this is the first case that I did in 2018 with dynamic navigation. A single implant placement in maxillary arch. And I decided that I want to evaluate in my first surgery that how accurate I am. What is the coronal deviation, what is the apical deviation, and what is the angular deviation. And here it is written that the coronal deviation was 0.2 millimeter. 0.2 millimeter coronal deviation we are talking about. Apical deviation was 1 millimeter. And angular deviation was 1.6, no, it is 2.9 millimeter. 2.9 degree. Is it acceptable? If I say my coronal deviation was 0.2 mm, is it encouraging enough to start the journey with that? If I say my apical deviation was hardly 1 millimeter, that's how accurate you can go with this system. Now the zygomatic implant. When we talk about zygomatic implant, we are going 41 mm, 47 mm inside. Here is the zygoma cases, what you can see on your screen. Here is a recent zygoma case which we did at my center 2 months back. I think there is some issue with the brightness, but if you can appreciate the 4 zygomas, one zygoma which has been placed. And with zygoma, we again like to evaluate that how accurately I have placed my zygomas. And coronal deviation was 4 millimeter, apical deviation was 4 millimeter, angular deviation was 4 millimeter. And this implant was placed at the depth of 41 millimeter. And that's how accurately you can place even zygomatic implants. So here we have check accuracy for all the 4 implants. And it was a very positive case. We took a scan, complete digitalization, and this is the final result with that case, what we got. It was a case of mucormycosis. Patient got infected with fungi in the second wave of COVID last March. And after 1 year of follow-up, we started the case and completed in time. But still, the only missing puzzle for the entire case in a digital workflow was jaw relation of the patient. How many prosthodontists are over here? So, prosthodontists will always realize that no matter what technology we are using, still we are using static bite of the patient. When we talk about occlusion, your even scanner is going to record only 1 bite. So there is a new device available which is called dynamic jaw relation device, which can help you to record dynamic jaw relation. Just pay attention on this video, what is being actually done. So when we are taking a scan, if it is for maxillary arch, you just take the maxillary arch scan, then mandibular arch, and then take a bite of the patient. With this particular system, a bite fork has been patented. It's a German-made device. A bite fork is used along with the bite registration paste. And after placing it on the maxillary arch, you take a second scan with top of it. So first you take a normal scan of maxillary arch, then you place this bite fork and take another scan. This bite fork can be attached to a sensor. And that sensor will show you how patient's lower arch is moving. This is called JMA optic. It is a Zebris system from Germany. So there are 2 options with the system actually. One is the wireless, as you can see it is operated with the Bluetooth. The second cost-effective one also comes with wires, which you can connect to your laptops. And here you can see how patient's mandibular arch is moving. And this file directly goes to Exocad. I hope, prosthodontists, you know Exocad, right? So Exocad is the software where each and everything is planned. If you are going for simple crown and bridge or any of the implant processes, everything has been planned in Exocad. And this is the only system which is now calibrated with Exocad. So you take the scan, it will go directly to your Exocad and your lab will plan accordingly. So occlusion, that missing piece of puzzle, is also now being solved with technology. Here showing another case for the sinus elevation or the sinus lifting. Whether you are going for the indirect sinus lifting with the densa burst, you can calibrate them. Or if you want to create one window and then want to go for the direct sinus lifting, it is achievable. Now you know the screen. This is a clinician doing the treatment, OPG view, buccopalatal view, mesiodistal view. Here the state handpiece has been used, implant has been planned, and even the prosthesis has been planned along with it. First we are doing calibration of the drills that we are going to use. It is artificial intelligence. It will always tell you that whether your calibration is proper or not. You need to recalibrate or not. And here, can you see this arrow? This arrow is showing you continuously that where you are hitting the bone. Theoretically, it may seem a bit difficult, but hopefully in future when we'll get a chance for the live surgery or live one-to-one session, we'll show you how this entire technology works very seamlessly. Next, another case with dynamic navigation. This is just for the patient education and the student education purpose, where we are showing that how we can use it for the central incisors. We'll take a small break first for inauguration ceremony, and then we'll continue from this side.
एक घंटे से कंटिन्यू चल रहा है मन कर रहा है तो मत कर और मैं बताऊँगा उसका पूरा शूट करूँगा। वैसे लाइव पे लगा के छोड़ के रखना, लाइव उनको दिखाना। लाइव चल रहा है अभी, लाइव चल रहा है भले रिकॉर्डिंग होना है ना, रिकॉर्डिंग मतलब अपने हिसाब से रिकॉर्ड कर देना थोड़ा थोड़ा बीच में। मैंने तो कंटिन्यूसली कर दिया रिकॉर्ड, चल ही जाता कंटिन्यू। लंच में क्या कार्ड खाली कर लेंगे, डेटा ट्रांसफर कर लेंगे। चेयर बहुत आदमी खड़ा नहीं है, खड़ा आगे कर लेंगे। देख लेते हैं वही लगा जब स्टार्ट हो ना कोई बोलने लगे बड़े बड़े सब्जी अभी तो तू आना है तो बैठा हुआ
Each sunrise is a fresh start, a new day, a brand new pencil on an empty page. Every day is a new beginning. Take a deep breath and let's start again. With the new sunrise, we can see some new faces on the horizon of the dentistry, and in our college, an assembly of galaxy of intellectuals, invited guests, teacher, practitioner, and new budding dentist. With these lines, I would like to welcome all esteemed guests, head of the departments, teacher, student in Digital Dentistry Congress to at Rishiraj College of Dental Sciences and Research Center, Bhopal. I, Dr. Sonal Tripathi, Senior Lecturer, Department of Prosthodontics, welcomes you all and here wishing a very hearty good morning on behalf of entire Rishiraj family. Let's start with the inauguration ceremony. Light is a symbol of brightness and prosperity. As sunlight expels the darkness, similarly, the blessing brings in our life the happiness. To make this morning a blessed one, invoke Goddess Saraswati by kindling a lamp of knowledge and wisdom. I would request all the honorable chief guests to please come for lamp lighting ceremony. Thank you, sir. Moving forward in this program, I would like to introduce the person who is a motivation and inspiration in his own unique way. The man who holds the chair of Secretary of LNCT Group of Colleges and enthusiastic and hardworking is none other than Dr. Anupam Choksi, sir. We are privileged to have you amongst us, sir. I request Dr. Prashant Jaju, sir, HOD, Department of Oral Medicine and Radiology, to please welcome Dr. Anupam Choksi, sir, with the sapling. Thank you, sir. I am highly honored and feel privileged to have been given this opportunity to welcome our honorable chief guest, Dr. Surendra Agrawal, sir, on this special occasion. Sir is the eminent prosthodontist member DCI for 2 terms 2007 to 2012 and 2020. Presently, member State Dental Council for 2 terms. Sir is the past president IDA, MP State Branch, ex-professor, head of the Department of Prosthodontics in People's College of Dental Sciences and Research Center, Bhopal. Sir has been DCI Inspector, past editor, IDA, State IDA General. Sir is the Central Council member, IDA Head Office, EC member, Indian Prosthodontic Society for 2 terms. Sir has also organized Inspector Training Program and Golden Jubilee Function for Dental Council of India. I am honored to have you amongst us, sir. I request Dr. G.S. Chandu, sir, Dean and Head of the Department of Prosthodontics, to please welcome Dr. Surendra Agrawal, sir, with the sapling. Thank you, sir. It's time to welcome a very energetic and motivating magnetic personality serving as Dean for this institution, Professor and Head of the Department of Prosthodontics, Crown Bridge and Implantology, Dr. G.S. Chandu sir. I request Dr. Siddharth Gupta sir, Professor, to please welcome Principal sir with the sapling. Thank you, sir. I'm extremely overwhelmed to welcome Dr. M. Shiva Shankar sir, Professor, Department of Digital Dentistry, Babuji Dental College and Hospital, Director, Confident Dental Laboratory, Bangalore. We are really grateful to have you amongst us, sir. I would like to request Dr. Ambika Srivastava ma'am, Professor in Department of Prosthodontics, to please welcome Dr. M. Shiva Shankar sir with the sapling. Thank you, ma'am. I feel privileged to welcome Dr. Anshul Dinesh Chandra Male sir, who is a rising star in digital dentistry and a very well-known prosthodontist and implantologist practicing in Surat, Gujarat. I would like to request Dr. Kriti Srivastava ma'am, Reader, Department of Oral Medicine and Radiology, to please welcome Dr. Anshul Male sir with the sapling. Thank you, ma'am. I'm honored to welcome Dr. Neeraj Kinariwala sir, who is a well-known microendodontist and co-author of the first book on guided endodontics and with many feathers attached to his cap. I would like to request Dr. Shashidhar sir, Head of the Department of Oral Pathology, to please welcome Dr. Neeraj Kinariwala sir with a sapling. Thank you, sir. Now we have our very own and very enthusiastic personality sitting amongst us, Dr. Prashant P. Jaju sir. He is the OSD of our institute, Head of the Department of Oral Medicine. We are very happy to welcome Dr. Yogesh Sharma sir in this Digital Dentistry Congress. I request Dr. Ashish Sharma sir to please welcome Dr. Yogesh Sharma sir. We are privileged to have amongst us Dr. Sanjeev Tyagi sir, Principal and HOD, Department of Conservative Dentistry and Endodontics. I request Dr. Faisal sir to please welcome Dr. Sanjeev Tyagi sir. I am honored to welcome Dr. Ramachandra Reddy sir, HOD, Oral Medicine and Radiology, People's Dental Academy. I request Dr. Neeraj Gupta sir to please welcome Reddy sir. I am honored to welcome Dr. Naveen S. Yadav sir, HOD in Department of Prosthodontics, People's Dental Academy. I request Dr. Namrata ma'am to please welcome Dr. Naveen Yadav sir. We are privileged to have amongst us Dr. Sumit Narayan sir, Head of the Department of Periodontics, People's Dental Academy. I request Dr. Vijendra sir to please welcome Dr. Sumit Narayan sir. Thank you, sir. Moving forward, it's time for the welcome address by our dynamic and motivating principal sir. I would like to call upon the stage Dr. G.S. Chandu sir for the welcome address.
morning, everyone. So, with the grand success of our Digital Dentistry Congress 1 during last year, and as we have promised, to come up with the second session of Digital Dentistry, we are here with the second Digital Dentistry Congress 2022. It is my pleasure to welcome each and everyone for the Digital Dentistry Congress 2 for the 2 days from now onwards. For this, I would like to invite our welcome our Chief Guest, Dr. Surendra Agarwal sir, who is a member of DCI and he is a very eminent prosthodontist and a practitioner in Bhopal. I welcome Dr. Surendra sir on behalf of Rishiraj College of Dental Sciences and Family. So the next, our guest of honor, none other than our LNCT Group Secretary, the man with the vision, Dr. Anupam sir, who has taken out his precious time to grace this occasion with in between his busy schedule. So I welcome Dr. Anupam sir for our Digital Dentistry Congress. Next, we have an array of eminent speakers. As you know, Dr. Shivashankar doesn't require any kind of introduction. So I welcome Dr. Shivashankar for his valuable presence and gracing the occasion. Next is Dr. Anshul Mail, who is also eminent personality in digital dentistry. I welcome Dr. Anshul Mail. And the next one is Dr. Neeraj Kinariwala, who has started already this lecture, but now he is waiting for the continuation of the lecture eagerly, and you are also waiting for his lecture. So sorry to interrupt, sir. And I welcome you to the Digital Dentistry Congress 2. Apart from this gathering, we have my colleagues, principals and HODs of the different colleges, Dr. Sanjeev Tyagi, Dr. Naveen Yadav, Dr. Ramchandra Reddy, Dr. Sumit Naran, and our own faculty, HODs, faculty members, and delegates. Delegates are the very important persons for the success of our Congress. I welcome you all one and all, and hope you will enjoy the learning process for the next 2 days. Thank you very much.
Thank you, sir. I would like to invite Dr. Yogesh Sharma sir to say a few words to our participants.
Good morning to one and all. It's my proud privilege to be here as part of this program, scientific program. And I'm very happy that LNCT Group, Rishiraj College, part of it, is back-to-back conducting such scientific programs. And this is what is the basis. And to our students, I would like to say that when you have so much of programs on digital dentistry and the sophisticated modalities, but still you should not forget the basics of medicine. So all these gadgets will only be useful when you have a sound knowledge of the basics. So I wish you all the best, and Dr. Gaju and team, best wishes for this wonderful program. Thank you.
Thank you, sir. I am highly honored and privileged to call upon the stage Dr. Surendra Agrawal sir, member MP State Dental Council, for sharing his few precious words.
dear colleagues and students. I'm very happy to be here for the second time. I was a part of this digital dentistry part 1, and I'm very happy to see the full attendance and a lot of people who are enthusiastically attending this program for the second time. And I'm seeing the growth and the success of the program. And I was talking to Dr. Prashant, who has organized his team. I saw the magnitude of this program for the second time, the first time and the second time. The second time it is in a much more bigger magnitude, and I understand that they are going to have the third part also very soon next year, and they'll keep on doing these series of programs like you have nowadays. You have movies which comes in part 1, part 2, part 3 and ongoing program. Same way I expect that this program also will have a never-ending program, and I appreciate all the dignitaries who have come from other colleges, Dr. Sanjeev Tyagi, Dr. Naveen Yadav, Dr. Sumit Naran and all the people. I must appreciate the speakers who have come from all over the country, especially Dr. Shiv Shankar, who is the permanent part of this program, and he, as Dr. Chandu said, he needs no introduction. Probably he is the first person in the country to work on digital dentistry, and he is a master in digital dentistry. And I hope that you all will gain a lot of knowledge, and it will be very useful for you all to learn digital dentistry and implement this in your clinical practice. I must congratulate and thank the organizing committee, Dr. Prashant Jaju, Dr. Siddharth Gupta, Dr. Ambika and their entire team. I am very thankful for calling me here. Thank you so much and wish you all the best.
Thank you, sir, for enlightening the audience with your words. I would like to invite Dr. Anupam sir to say a few words.
Chief guest of this conference, Dr. Surendra Agrawal, Dr. Yogesh Sharma ji, all the dignitaries on the dais, faculty members, students and all the learners, I must say, who are here to attend this 2 days workshop, seminar, whatever you can want to say. But only thing, as the experts are there, और डेंटल के बारे में मैं ज़्यादा कुछ नहीं कह सकता, but learning के बारे में कह सकता हूँ कि this is a golden opportunity for everybody. जब ये इंडक्शन प्रोग्राम है, किसी में बात करता हूँ तो मैं कहता हूँ कि कॉलेज कैन प्रोवाइड यू अपॉर्चुनिटीज ओनली. एक इंस्टीट्यूशन आपको अपॉर्चुनिटीज प्रोवाइड कर सकता है, सीखना नहीं सीखना. जो आप बैठे हैं, आपके सामने एक्सपर्ट्स बैठे हैं, इनसे सीखना है कि नहीं सीखना, ये आपके हाथ में. सर ने कहा कि ऐसे कई सारी वर्कशॉप 1, 2, 3 ऐसे 100 भी कर लें और जो पीछे बैठा है उसको सीखने की कोई इच्छा नहीं हो, वैसे 100 वर्कशॉप अटेंड करने के बाद भी वो वहीं का वहीं रहेगा. और जिसको सीखने की अच्छी रहेगी इच्छा, वो 2 वर्कशॉप के बाद भी अपने आप को एक्सपर्ट मान सकता है. फिर दूसरा पॉइंट आता है कि जिसने अपने आप को एक्सपर्ट मान लिया 2 वर्कशॉप के बाद, तो फिर मतलब देखिए क्या है कि मैं तो मजाक में कहता हूँ कि तो आज की डेट में डॉक्टर्स की संख्या बढ़ रही है. अब हमको देख के जाना पड़ता है डॉक्टर के पास कि भाई कहाँ से पढ़ा, कैसा पढ़ा. अब वहाँ जाके पूछना नहीं जा सकता. So I always say that learning is a continuous process. और जो अपने आप को ये मान ले कि मेरे को सब कुछ आता है, उसको कुछ नहीं आता. So you should always try to keep learning. और ऐसी वर्कशॉप सेमिनार्स हम ऑर्गेनाइज करते रहेंगे. मेरा सर लोगों से रिक्वेस्ट रहेगा कि अगली बार हम इसको LNCT यूनिवर्सिटी के जो ऑडिटोरियम है वहाँ करें, और जहाँ 100 की जगह 1000 बच्चे भी जो भी लर्नर्स हैं उनको बैठा के ऑर्गेनाइज कर सके और एक्चुअली हम इतना अच्छा प्रोग्राम ऑर्गेनाइज कर सके.
Thank you, sir, for your kind words. Now, I would request Dr. Anupam Choksey, sir, and Principal, sir, to please felicitate Dr. Surendra Agrawal sir with a token of appreciation. Thank you, sir. Now, I would like to request Principal Sir and Dr. Anupam Chowse sir to please welcome Dr. Yogesh Sharma sir with a token of appreciation. Thank you, sir. I would like to request Principal Sir and Dr. Anupam Chowse sir to please felicitate Dr. Shivashankar sir with a token of appreciation. Thank you, sir. I would like to request Principal Sir to please felicitate Dr. Anshul Dinesh Chandra Male sir with a token of appreciation. Thank you, sir. I would like to request the dignitaries to please felicitate Dr. Neeraj Kinariwala sir with a token of appreciation. Thank you all the dignitaries. A poster competition was conducted for Digital Dentistry Congress for undergraduate and postgraduate students to make them aware regarding upcoming digital era of the dentistry, in which a total of 25 students participated and presented their e-poster. I would like to request our esteemed guests to please give awards to our winners of the poster competition. In postgraduate category, the first prize goes to Dr. Humaira Hassan, PG, Oral Medicine and Radiology. Second prize goes to Dr. Anjali S. Sharma, PG, Department of Prosthodontics. Third prize is shared by Dr. Nitin Matthews and Dr. Anushi Patel, PG, Prosthodontics. Our undergraduate students gave surprisingly superb presentation. So for the intern batch, the first prize is shared by Kapil Malviya and Arhan. shared by Shivam Patel and Anisha Sharma. It's Amisha Sharma. In final year category, the first prize goes to Kostol K and Sonali Devi. Second prize goes to Jocelyn Jacob. Thank you all the dignitaries. I would like to request Dr. Ambika Srivastava ma'am, Professor, Department of Prosthodontics, to please come on the dais for the vote of thanks.
Good morning, everyone. Good morning, sir. I, Dr. Ambika Srivastava, Professor, Department of Prosthodontics, Crown Bridge and Implantology, am honored and privileged to propose the vote of thanks on this special occasion. I would like to thank firstly our chairperson and our secretary, sir, Shri Anupam Chokshi, sir, and our management for giving us this opportunity for conducting this beautiful digital dentistry congress. Sir is always a guiding light of our group. I am obliged to thank Dr. Surendra Agrawal, sir, who has taken out time from his busy schedule to be a part of this congress. Thank you, sir. I am thankful to our principal, sir, Dr. G.S. Chandu, sir, our vice principal, Dr. Nishant Chaurasia, our OSD, head of all the departments, and our colleagues for their constant support. I am grateful to the galaxy of our speakers, Dr. Shiv Shankar, sir, who is a stalwart in prosthodontics and digital dentistry, for being our pillar of strength of DDC. Thank you, sir, for taking out time to be here. I am thankful to Dr. Neeraj Kinariwala, Dr. Anshul Main, Dr. Abraham Johnson, Dr. Panos Diamantopoulos, and Dr. Prashant Jaju for sharing their knowledge and opening new horizons for all the participants of DDC too. I am thankful to Dr. Yogesh Sharma, sir, for being here. I am thankful to all the head of the departments, principals, and participants from other institutes who have made this congress a huge success. I am grateful to our sponsors for our program: Bioline Implants, Shell Dental Systems, Dio Implants, Dentsply Sirona, Digident, Anu Dental Lab, Oricam, Phoenix Pharmaceuticals, and Ibon Pharmaceuticals for their support and agreeing to be a part of this congress. My vote of thanks would be incomplete if I do not thank the team who has been working day in and day out to make this program a success. I would like to thank Dr. Shashidhar sir, Dr. Ashish, Dr. Narumrita, Dr. Dakshita, Dr. Neeraj, Dr. Faisal, Dr. Brijen, Dr. Shweta, Dr. Sonal, Dr. Kirti, Dr. Purva, and Dr. Siddharth for being a strong and cooperative team. I am thankful to all my postgraduate and graduate students who listened to me and agreed to be a part of the e-poster competition. I am thankful for being always there for when we need help. I am thankful to our IT department and Dr. Mr. Narula and the OSD of Group, Dr. Sunil Singh. The event would have been incomplete without their support. And also I am thankful to our class 4 employees for always being when we need them. Lastly but not least, I am thankful to God Almighty for being bountiful. Thank you one and all.
Thank you, ma'am. Thank you all the dignitaries I would like to request to join us for the trade fair inauguration followed by high tea.
To share a piece of information that we have an IDA MP State Teleconference in the month of first week of January, and your own Vice Principal Dr. Nishant Chaurasia is the organizing secretary for the same, and request you all to take participation in big numbers. And any more information you can take from Dr. Nishant Chaurasia.
तो डिवाइस से ऑडियो उसमें क्यों नहीं आ रहा? उस डिवाइस से ऑडियो उधर क्यों नहीं जा रहा?
डिवाइस से ऑडियो नहीं जा रहा है।
मैंने चेक कर लिया, उसका तो जा ही नहीं रहा, अपने लगाया केबल।
ऑडियो तो नहीं जाएगा,
इससे तो जा रहा है,
इसी से जाएगा, उसका पर्सनल नहीं
उसका हेडफोन जो है चलता है कि चलता है, सुनाई देता है उसका?
देता है।
तो अभी जा नहीं रहा, उस पर केबल लगी हुई है।
अपनी हेडफोन लगा के चेक करके
चेक करो, हेड करो,
हाँ,
चेक करो।
इसको ऑन करना।
ऑन ही ऑन है। आ रही, इससे तो आ रही है, उसमें नहीं जा रही ना। अपन बोल रहे इसमें आना चाहिए ना स्पीकर में, वो तो भले हम बाद में बंद कर देंगे। मैंने क्या जब वहाँ चलेगा ना तो उसके बाद हाँ आनी चाहिए ना। लाइव चल रहा है ना अभी, बंद थोड़ी ना दिया। हेलो हेलो हेलो, नहीं आ रही ना, साउंड नहीं आता। तो परेशानी हो, एक बार पूछो फ़ोन करके उनसे, भैया से चेक। हेलो 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 हेलो, उससे बंद तो नहीं होता अंदर से? पूछना भैया से, पूछो ना एक बार। साइन का पोजीशन में है ना, वही करना होगा। हाँ बात कीजिए।
पोइट्री में आना जो है, हाउ आर यू सोनल? यू आर डूइंग अ गुड जॉब हियर, एंजॉयिंग कॉलेज। हाँ, आई एम सरप्राइज लोग बोल रहे हैं कि कितना अच्छा है। इनफैक्ट ये भी भेजी देते हैं उसके साथ। आई स्वेयर मेरे को टाइम ही नहीं मिल रहा था बिल्कुल भी। उसने मुझे रात में सोते वक्त बताया जरूर था, तो बोल के मैंने उसको एक दो टिप्स दिए थे ऐसे।
लिखा हूँ करते हैं इस तरह से लिखा होता है। ऐसा पेन नहीं है था, ये लगती थी मतलब रात में रखती थी वो हाँ भैया हाँ ठीक है।
No, for me it's okay. For me it's okay. You want to do attempts also?
Yeah, that's okay.
So yeah.
Whatever you see, I am making arrangement everything. Last one so I didn't get time. Because of you, I have.
How, which patient? Mevla or current patient?
Also, one is this sign
Karan is at this one.
Distal exercise. Right mandible distal exercise.
इसमें इन कौन सा कैमरे में, इन कौन सा कैमरे में, ऑडियो इन, तो वो है BNC, इसमें कैमरा भी आउट इन भी तो होगा केबल लगाने के लिए।
देखो इधर हुआ,
ये मिल गया हाँ, ये रहा, यही ऊपर वाला माइक, हाँ यही है,
हाँ
ठीक चल।
देर हो गया।
All of you please settle down. We'll continue with the lecture of Dr. Neeraj Kinariwala sir.
Hello everyone, I hope everyone is settled down. Good afternoon. We started in the morning and still we're continuing the noon session. I won't take more than 10 minutes of your time. Okay, since everyone is settled, I can start the last part of today's presentation. In morning session, what we went through was the static navigation for implants and endodontics. We started with dynamic navigation for implants and endodontics, and the last part, which is left, is use of dynamic navigation in endodontic microsurgery, where we try to apply. Now it's important to know that why for endodontic microsurgery, navigation or guided treatment can be of some use. Because there are three challenges that we face while we are dealing with endodontic microsurgery. The first challenge is that we want to do osteotomy, and it is to be very precise and minimally invasive. At the same time, we are looking at the accurate root and resection. When I talk about accurate, it is about not compromising on the crown root ratio. So we just want to make sure that we don't end up cutting more than 3 mm of the root end. And the third and most important one is the angle of root end dissection. At which angle we are going to resect the root. You can call it targeted endodontic microsurgery or guided endomicrosurgery. End of the day, we are using it for the diagnosis and treatment planning. CBCT will start our approach. Then it goes to root and resection surgery. Sometimes even indirect sinus lift can also be incorporated. For autotransplantation, it has been used extensively. And the most important is the educational model when you are beginning your career. This is an article from American Association of Endodontics just published last year, which says that periapical microsurgery, this is the era of renaissance, and we as endodontists need to grab this opportunity to even doing apicectomy in maxillary 6 or mandibular second molar with the same accuracy and predictability, and how we can try to achieve that. When we are going for surgical endodontics, we are not forgetting the very basics of surgery, a good incision, flap. The technology is only going to help you during your osteotomy part, your treatment while you are going for root and resection, and you are selecting which angle you want to resect. Apart from that, everything lies in clinician's hand. So as a clinician, you need to plan your case on the software first. You decide that at what level you want to do root and dissection. Once you complete your planning, now this is called, if you can recollect from the morning session, this is called trace registration. So now we are recording and superimposing the DICOM data on patient's existing intraoral condition. Trace registration will correlate 100 landmark on every teeth. We have selected 3 landmarks, and here you can see while in real time our drills are moving. The green color shows where my drills are moving and exactly where we are dissecting the root end. You decide you want it at 3 mm, it will be at 3 mm. And you can see that in real-time navigation. You can also achieve a good angle at the root and dissection. With microsurgery now we say that we want a 0-degree bevel at the root end for the better attachment of the periodontia. That's exactly what you can achieve. Sometimes you can also combine it with the 3D printing for the posterior-most cases where it can become 100% accurate treatment. You have to use trephines and calibrate it with the Navinet device and start doing apicectomy. There is a technique which has been developed and it is called cortical window technique. So if you are dealing with any region, the osteotomy cut that you want to put, you create a window, take it out and then put it back as a lead. Once you are done with proper curettage, root and filling, and that's why we call it cortical window technique. You take out the bone and put the same bone lead again over top of it. And it will make sure that your surgeries are minimally invasive. But that is taking nothing away from the periapical curettage. See, digitalization will only help you to do root and dissection. But if there are any foreign bodies, granulomatous tissues, you have to scoop them out and it lies on your clinical skills. How you clean the periapical area efficiently. Here you can see some excess materials, gutta-perchas are being removed from periapical area. I will just show you how precise the root and dissection can be achieved. Here you can see the 0-degree bevel has been achieved and following that root and preparation has been done with ultrasonics. And root and filling was achieved. There is the cortical window technique. So all I can say to some of my presentation that dynamic navigation dentistry is accurate, safe, immediate. But I would just like to highlight the main difference between static navigation and dynamic navigation. When you are planning your treatment, for static navigation, DICOM and STL files are must. For dynamic navigation, you can skip STL file. STL file is still optional. Only with the DICOM data, we can start the dynamic navigation surgery. The triple planning softwares are inbuilt. You are not dependent on any third-party software. And just the last case of auto transplantation. These are the cases where horizontally impacted third molars, they spoil the prognosis of second molar and we end up removing second molar and third molar. Such type of cases, auto transplantation has been adapted, but what are the biggest challenges when we talk about auto transplantation? What is going wrong? Why we are not using it or you are attempting it in day-to-day basis? Because the extra oral dry time for the expected tooth, modifying the socket for that expected tooth, that is the challenge for a clinician to achieve within a given time period. So what we normally do is that when you have your DICOM data, just section the third molar part, get it 3D printed, and after removal of the second molar, try to fit this 3D printed model inside the socket. So that will reduce the extra dry time for the third molar that you want to do. So for this auto transplantation, you are not only relying on dynamic navigation. 3D printing is the first step that you have to opt for. Following 3D printing, you can superimpose the existing root structure of third molar on the second molar socket and modify entire socket. This technique was proposed by Dr. Felipe Restrepo, he's a friend from Mexico. And this technique is being widely used now as a combination of static and dynamic navigation for auto transplantation cases. So here, if you can appreciate, a pink color outline is the STL file of the tooth being auto transplanted. So you place it superimpose over existing DICOM data and then modify the socket after extraction. And you try to fit the 3D printed model, it will reduce your extraoral time, and root canal can be opted later on depending on the vitality test. I would like to sum up my presentation by saying that I have been visiting many dental colleges in this year particularly with dynamic navigation and aeronautics from AIMS Dental College to Savitha and Vishnu Dental College. This is AIMS Dental College. And today, thank you, Rishiraj Dental College, for having me over here. I always say at the end of my session, you are what you believe yourself to be. You can reach out to me for any further queries. Thank you.
Audience, any questions? Okay. Thank you, sir, for throwing a light on how dynamic navigation utilizes a real-time tracking technology to enhance the accuracy of endodontic procedure and implant placement. I request Dr. J.S. Chandu, sir, to please give a token of appreciation to Dr. Neeraj Kinariwala, sir. Thank you, sir. I request Dr. Siddharth Gupta, sir, Professor, Department of Prosthodontics, to please come on the dais to introduce Dr. Anshul Dinesh Chandra Beel, sir.
Good morning, everyone. First of all, I am so happy, delighted, and I am so thankful to all of you to be all present here for our second edition of Digital Dental Congress. This is like a dream come true, and when we have speakers like Dr. Shiv Shankar, who agreed again to spare his time and his valuable thoughts and his knowledge with us, I cannot ask for anything more. But this year, we have another galaxy of speakers who are upcoming in the field of digital dentistry. I have a written note in front of me about the speaker who is about to come next. So first I'll read that, and then I'll share some of my thoughts about Dr. Anshul Mil. So implants have become the mainstay in dentistry, as we all know, and digitalization has increased the predictability, and because of the implant planning that we are able to achieve before even the implants are placed. I am glad to introduce Dr. Anshul Dinesh Chandra Mel. He has done his BDS and MDS from Rajiv Gandhi University. He is specialized in multiple softwares using digital planning. He is also the key opinion leader for Bioline Implants, Ruthium Group, and many other groups. I am excited to invite such a young entrepreneur to take up the stage next. And I would tell you guys to learn from guys like Dr. Anshul here and Dr. Neeraj, because these guys should be your examples, and you should be following such guys, because what I appreciate the maximum in these two people here with us is that they always knew what they wanted to do in dentistry. They were never confused. And I have seen undergraduates, I'm myself a postgraduate teacher, I've seen postgraduates also confused how they should go about it, where should be there. But I think the clarity of thought process with these two guys show, Dr. Anshul and Dr. Neeraj, is something we should be all learning from. Dr. Anshul, for example, knew from the very beginning that digital is his key. And now in India, as if praises are coming from Dr. Shiv Shankar, you can well understand where Dr. Anshul stands. I am short of words that I am being given this opportunity to welcome Dr. Anshul. Last year also, when Dr. Shiv Shankar was here, we were talking about you, Dr. Anshul. And last year also, we had decided that whenever we do this conference, it would not be without you. So I am happy, and it's my honor and privilege to invite you as our next speaker. Thank you.
Thank you, sir, for waiting so much for me. And just want to tell you, just you keep this light on, but you keep this light on. I want they should be awake.
Don't worry, actually, they'll be awake.
And I am one of them only. I am a backbencher, okay? So I am sitting on the back side and sleeping. But to be honest, my life changed after 2012. First lecture I have attended, as you only I am sitting on the back side, and that lecture, luckily I am awake. And the speaker is Dr. Siwan. Okay, and on that day they are just doing cutting, scanning, on the same side they are doing milling and they are demonstrating. So that booms my brain like something we have to do and future going to be digital dentistry. Then I jumped after my prosthodontics into digital dentistry directly because of him. So I am very much thankful.
I'm honored.
Yeah. So nowadays all are implantologists. There is no field deviation. If you see any clinic, everywhere they are written implantologists. Okay. And implantologists have three problems. One is they have to place implant. Place हो गया, अभी resorption हुआ तो graft करो, नहीं हुआ तो prosthetic करो. ठीक है, तो prosthetic कैसे करना? So all problems are there, and it is universal, not us. Like I'm doing out of India, also the same scenario is there. So everywhere that people are placing here and there, and we feel like they are much better, but they are also same way only. Okay, so things are same only. So me, like I'm a Dr. Anshul Male. I have my 8 patents and 4 under patents on digital dentistry only. And just we are trying to get a better solution and very easy way. Okay, like we have the same way, like we have 3 options to pass on our message. Okay, like one is manual, another one is like by other person, like consultancy coming, and third one is like we are doing mail. So now like technology are changing nowadays. Okay, so we have to cope up with the technology. The same way, like the dentist is the same only. So as morning sir told, like we should good with the basic. Okay, so basic compulsory is required even to do whatever you do. Okay, but what the technology is helping us is like to get the result easy way. Okay, not you rely on that. Example I am telling you, in the market, like if you give a lab, work to the lab, they will say, sir, you do CAD, you will get 100% result. It is not like that. It is how you place implant. Where is your implant and what is the position of your implant. So now if you are, and the advantage of digitalization, like you can connect each other easily. Like as we have over here, some have seen a social media advertisement, some have seen a WhatsApp message. So it's very small word because of social media. And like you have a lot of opportunity to learn it. When I have started, I still remember like on a first page of software, I have to fill it up and go to the next step. Okay, so I took 2 months because no one is there to teach. No, there is no video on YouTube. There is nothing. Okay, so like how to fill the form, that also we don't know, like how to go to the next step. So this is the thing, like nowadays like we have a lot of social media networking, so like you can easily connect. So how many over here PG students? So you have implant in your department, facing implant. So what is your treatment on this? Simple, very simple. Tell anyone. See, this is interaction, okay, and that's why I'm coming here, so everyone can avoid this.
Very small, you put one implant over there,
Yes.
and also you can put one implant over in the premolar.
Yeah, so this is the actually advantage of digital technology. As like maximum people are thinking like wherever the missing tools are there, we will replace with the implant and finish of the thing. But this is 2D. You cannot rely on 2D. So all are, we have different digitalization. So we have to select which to use or which not to use. The same case, if you see anti-anterior hanging, okay, so you cannot expect much life. So you can plant right now only so you can preserve the bone for a longer time. So this is the thing, like you can cope up with the digitalization if if you are just relying on the OPG, then you just leave the anterior thing. So like this, you have to cope up with the techniques. So what is our goal, main goal? Like we have to achieve our goal, like we have to throw the ball into the perfect center, like as we have to place implant or do any treatment which is easy way. Okay, but all games have their rules. We cannot apply cricket rules in a billiard. Okay, and we cannot apply billiard in the cricket. Okay, so same way, if you want to go ahead with digitalization, like also you have to, it's a complete different field. You have to understand. Okay, it is not like I am doing basic, so I easily am getting it. Okay, you have to apply your basic knowledge to cope up with the technology, then you will get easy way your result. If you are not following, see this is the actually thing nowadays doing in the market. I will send this video. This is my surgeon who is cycling it. He is doing so many implants free hand. Okay, so now he is on guided surgery. So he is like this. He is very happy. He got the guide. He is taking implant along with him. Okay, and what happened? Okay, because he is not much aware about the technology. Okay, so either first thing we have to do is, if you know, yeah, you know the basics. Okay, but basic of technology also you have to understand, because this is engineering field completely. So engineers they are understanding our line and they are creating the software, so we have to understand their line also. Okay, so this is the thing, like most of the time I am getting, and they are saying, yes sir, guide acha nahi tha. You have to repeat the guide, or you have to transfer this money to the next case, like that. So without doing, without knowing technology is killing, you are killing the technology. So if you start with the guided like digitalization in implantology, like my topic is on implant today. So the basic part I hope, like you require CBCT first of all perfectly, and the what area you want to require. So that is most important part. Then with the help of CT scan data, we can create the guides. Okay, so we require intraoral scan or CAS scan and the data, CT scan or CBCT data. So basic normal guides are like the good supported guide, like some of the teeth are laser-like. We have one case of OPG previously. Some of are there, some of are missing, and if you are doing, so it's a and completely dangerous. So like a tissue supported. So it is partial and complete. And nowadays 2 more guides are there. The bone supported, like if you want to do a bone cutting, bone flattening. Okay, if you have like some cyst over there, you want to cut it off and then you want to place the implant, or partial mandibulectomy is there and you want to place implant. So these are guides are bone supported. And the last is most common nowadays in my side. It's a second inning. So as like we, all of a like patient are like implant ready, like lifetime. Okay, so now what happened, like all implant or any industry have their own life. Okay, like implant companies also only recommending 8 to 10 years of like life of implant. Okay, then after that you have to do something. Okay, and this implant supporting guide for them, like now they cannot take the money, but the older implant we can take as a support to stabilize the guide and place a newer implant. So nowadays this is most common kind of guide we are creating. As I told before only, like we need to understand the technology, how it works. So we want to understand the requirement of the technology. Okay, technology ko kya chahiye, what its demand. So like we have 3 cases, edentulous, partial edentulous, and the guide for completely dentulous also is there. Literally surprised कि भाई पूरे दांत है तो क्यों implant करना? Okay, so like chronic generalized periodontitis means all the are mobile, all are moving. So you have to extract and you have to take out all infection and you can place the implant. So for that 3rd category is there. So like partially dentures, like everybody over here is know, and in afternoon also we are giving some demo on it. Like you require scan, CBCT data, and you can plant. But in that, if by chance some metal crowns or anything is there, so we have a lot of artifacts in the data. So we have to put composite and then we have to take a measurement. So this is the effect like कि भाई मुझे दो ही चीज पता थी कि भाई CBCT लेना और ये लेना है, पर जब मैं टेक्नोलॉजी में घुसा then I came to know like crown was artifacts आता है, so I cannot superimpose. So what I have to do? So this is the things we can do it. Then partial edentulous we can create RPD and take a CBCT, or we can directly onto the remaining thing. Like example, if we have anterior present distal extension is there both side, we can take a reference of the anterior and we can create it. And if you have completely edentulous, then we have a denture. We have to place a denture. We have to place the composite bone and take data. Why we need a denture? Any cases? If edentulous case are there, why we need a denture? Yeah, so exactly in short I can say your implants would be prosthetic driven, not a bone driven. So that's what I want. Always your implants should be prosthetic driven. That's why we need a denture. Okay, maximum time CBCT हो गया है, अब आप इम्प्लांट जितना बोन देखते हो उसमें इम्प्लांट डाल दो, फिर क्या होता है कि you have a posterior bone and your place little bit anterior and your cantilever is 6 is cantilever. Okay, so to avoid that such a thing, or sometimes because of good position and your bone position, you can select the abutment and you can ask your patient that you are going to charge extra because of this problem. You can convince your patient. The third one is like sometimes you have internal space as he told, like we have less, so we can trim it off and place implant down. So all things we can get it done and we have get idea about using a denture. And like earlier the photo we have composite ball as a marker, and in this the tooth itself is already open. So we have both options we can use it. But the important point is, can you see any difference between these two? Any radiologist, OMDR student? You are OMDR? Then you are safe.
I think these two, this light is switched off, then only you'll be able to see that.
Who's from radiology department? Yes, you can see what is the difference between these two. No. No, that is fine. But the simple differentiation between these two is, but in that side I have a denture while CBCT, but radiolucent denture base. Okay, and in this I have a denture which is completely opaque. Okay, so I will not plan my implant on it because I cannot see my bone clearly. So important point is that if you are using or creating a denture, this is also important. So when we are jumping inside, which a denture भी बना है, अभी भी तो आपको problem है, अब क्या problem? So this is a thing like you have shellac, or if you have light pure denture base, okay, both are very opaque. Okay, you have to work the pole pure clear acrylic. It is much better when you are creating a denture for the marker. Then last of like completely dentulous. Anything recognize what is the problem in it? So as I told, like all teeth are mobile. Okay, so if while scanning the tooth position is different and while CBCT will be different, so I cannot match both the conditions. So that's why I have to do splinting of the tooth first. Okay, and then I will take a impression and then I send patient for the CBCT. So for completely dentulous cases are there and we are looking for implant, then see what is the condition, why it's required implant. If teeth are mobile, then you have to stabilize it and then you can do it. Then why we need this? Because only tooth is a reference in clinical which is connected with the bone and it is a rigid reference. On a reference of that we are doing everything. Okay, soft tissue will not give a reference of both. Okay, so only tooth is a part by which we can take a reference and we can plan our implants. Then this is a type, different type of guides are there. Like we have to hold the sleeves and do a guided surgery. Then you have to change the sleeves, but breathe will be same. And the master guide, like we have like same guide but different drills are there to increase our osteotomy. But advantage of this last system is like if you have mouth opening like in molar, so you have mouth opening less, then you can go side and you can go guided surgery. So some of the advantage of selection of kit also is important, and understanding a kit, how to use that kit also important. It is completely different workflow than the freehand. Freehand only if you want to place 4x10, you have to do 2x10, 3x10, 4x10, finish the implant. But in this you have to do all 2x2x 2.7, 8, 8.5 and 3, 7, 8, 10 like that. You have to follow all back to back things. So that's why we need a guided surgery, because you are free and you are going blind. With the experience you will learning it. Okay, but if you have guided surgery, then you have some reference to easily you can do it. Just only you need to understand the technology. So first I told like some of the teeth are present and we want to place implant. This is the case like in which you can see on OPG, some of the teeth are present. But we are planning the implant on same position as well. We want to extend and place the implant. So what we have done is we kept the center as it is and remaining teeth we extract and we stabilize the guide and do a surgery. So why I done it, as I told like only teeth is a reference which is connected with the bone. So that's why I kept one tooth to do a guided surgery. So this is the post-operative of the same case. Now this is a new thing for everyone. मार्केट में अभी पेशेंट को इंडिया में 2-3 चीज चाहिए. देयर इज फिक्स. अब सबसे पहले मैं इतने रुपए दे रहा हूँ, मुझे फिक्स दांत चाहिए. मेरे पास बोन हो या ना हो, ठीक है. सेकंड थिंग इज कि मेरे जिस दिन दांत निकले उसी दिन मुझे फिक्स चाहिए. मेरे दांत वैसे दिखे या कैसे भी दिखे, मुझे उस दिन दांत चाहिए. एंड थर्ड थिंग, उसके दांत पूरे लाल हो, पान खाया हुआ, सब कुछ खराब हो, तो भी व्हाइट A1 शेडी चाहिए. ये फिक्स है इंडिया में. Okay. So to cope up this kind of condition, like this is one of my patent in fine one guide, in which you can place, you can extract the tooth, you can place implant, you can give prosthetic on same appointment. Okay, morning patient will come, evening he or she will take the teeth and go out with a fixed restoration. So like it has a 5 parts, as I will say, like it's 5 in 1. Because some splints, the base guide, the drilling guide, and on the top is prosthetic metal acrylic. So this is a plan for that page. Like some of the things are present. You want to extract, you want to place implant and give a prosthetic on same appointment. So this is a reference. So on a day of surgery, this is my clinical condition. Okay, I want to remove this teeth and place the implant. So what I will learn it, as I told, like it is my main reference. So I took a reference, I splinted my base guide. You can see there is 2 guides. One is orange and one is black. That's a metal one. So in a reference of teeth, I fixed my base guide. Okay, then I open up my top portion. So I can see my teeth. Okay, and then I am going to extract the teeth. So what I have done it, example, if I extract the tooth in software and give you a guide, so it is never matched with the clinical condition. It always differ. Okay, so because of that, I have created the foundation. Okay, then I am going to extract the tooth. Now I am going to remove the tooth and screw the top part onto the base guide. So now I have foundation, and on that foundation I am doing all my guided surgery. Place all implants, the multi-unit, then all cylinders, and then we pick up the cylinders in the metal acrylic prosthetic which is prepared before the. So this is a reference to keep the. This is the base frame, the reference here to pick up the metal cylinders. And we pick it up, we cut off the extension, we clean up the cement, we cut off the height of the cylinder and reinsert the insert the patient on the same day. So everything is done, and this is metal acrylic prosthetic, so it stay for longer time. And for upper regular guide tooth supported we have done, and we plan temporarily on remaining teeth. So this is our plan, and this is post-operative casing. The same way like I have done only just lower, and we have extracted tooth. as I told, like she told like we need a denture, we can decide a vertical height. So this is the same case. You can see we have done it. You can see the markers on the side, the balls. Can you see? So why we have done it? Because there is a denture, and on the denture we have took a CT scan. Okay. And after that we realized that we have very internet space is very less. We have sometimes बोलते नहीं कि भाई जिसके पास रुपए है उसके पास बोन नहीं, बोन है तो रुपए नहीं. तो ये केस ऐसा तो उसके पास दोनों चीज थी, luckily. So we have plenty of bone. We can place implant, but vertical height like internet space is very less. So we decided to cut off the bone and place the implant little bit down. So we'll get the space for the prostate. So on the same day, we want to cut the bone, we want to place implant, and we want to give teeth also. Everything on the same day. So morning 9 o'clock we start surgery, evening 6 o'clock patient have fixed prosthetic in the mouth with the. And the reference I got from the denture, preoperative denture. So midline, occlusal plane, and everything I got from the denture. So this is the first guide which indicates like how much bone you have to deduct. You can see the white color. So that's much of reference we have to deduct the bone. So you can see that is digital and this side is physical. And you can see the mounting on the physical side. So we have teeth already ready which contain mounting which we transfer all data from CT scan. So OMDR also have some value. Okay, give respect to them. So this is the mounting we have done. This is the drilling guide and everything is ready before surgery. So on the day of surgery, like we open the flap, we place the guide. You can see very nice edge. We cannot place on implant unit. So we plan to trim off that bulk of bone and then we place. So like this we can flatten up and then we have drilling guide. We insert the drills and do a planning and place the implant. So in the reference of the base guide, we took the implant. Now, I don't have any reference for occlusion, like to pick it up the prosthetic. Only have my base guide to pick up the prosthetic. Okay, so that's the main advantage of that base guide. So I have a reference. So right now I'm doing just upper, then I'm doing lower. Okay, but after both surgery, both upper and lower will be in occlusion. So this is a reference of this technology, what we are able to make this kind of things. So on the day of after insertion of prosthetic, and this is a post-operative things. Okay, so like we have complete metal acrylic prosthetic with all internal panel with each other. So like it's like that कि भाई शादी का I should go into digital dentistry or no? It's like शादी का लड्डू खाना है कि नहीं खाना है? वो खाए वो भी पछता है, जो ना खाए वो पछता है. ठीक है, but खाने के बाद दूसरा भी ऑप्शन है. Okay, so you should go in digital dentistry and this is just joke apart. So like Paula can stay with me on my speech. The same way like some of the cases we don't have much bone, so we are using customized implants. Like we have very less bone, and in that we have very thin zygoma. You have like you can see the outside, but inside there is no bone. So we in this condition we create a customized implant and prosthetic. Everything is on a prior to the surgery, and on the day of surgery we give everything. And for this kind of implant, the prosthetic is a reference to fix the implant. It's a reverse. You have to open the flap, place the implant, but don't fix it. Place the prosthetic, fix it, and then fix the implant. So it's a reverse process. Like and lower, like as we have done a bone flattening, the same way we have to do it. So this is a plan. If you want to cut off one part, yeah, and then we are planning the implant. So this is the guide to bone flattening. Then this is the implant. Then lower is guide and prosthetic. Everything is ready before surgery. So right now you can see there is no antagonist teeth. Everything is dentures. So we open the flap, we fix the guide, we trim off the bone at the level of that guide. So how much to trim you have a reference. That level you have to trim, not more or not like high, that level. And after flattening, we have base guide, we have a drilling guide, then you have to do a drilling. You can see very easily, you can do a drilling, you can see the site also on the day of surgery. and then you have to insert the implant. So by this we place all implant and we place the multi-unit abutment, we place the cylinders, we pick up the cylinders in the reference of base guide. Now still you can see there is no antagonism. Okay, I took it on a reference of my knowledge and my skill on creating the guide and the help of digital technologies. We pick it up, we clean up the extra cement, we cut off the extensions. My final prosthetic, and my surgery is closing that flap, and we insert the prosthetic on the same appointment. Now still I don't have any antagonism. Now our opposing arch surgery is going to start. So we open the flap. This is a bone cutting, so my abutment will be down and I can give a proper prosthetic. So after bone cutting, you can see this area, and in that slot you can fix the implant. So like this you can fix the implant. So just place the implant, fix the prosthetic, and then fix it with the bone. And once implant is fixed up, you open up the prosthetic, close the flap and reinsert the prosthetic. So this is you open up the prosthetic after fixation of implant, and this is the reinsertion of prosthetic on the same. So how it's possible? It's possible because of the technology. Why we are here? Because to learn like what level we are working and what we can do it. Okay, so we don't have a bone in our hand, but still our implant and everything is ready before surgery, and it is adapting as what we have planned. Okay, so this is the advantage of technology. So this is the post-operative OPG. Any question now? Because of this I just या तो सब समझ में आया या तो कुछ समझ में नहीं आया. इतना समझ में आया कि डेंटिस्ट डिजिटल डेंटिस्ट्री स्कोप है, तो इतना तो समझ में आया ना. हाँ बस वही चाहिए मुझे. So now is like bone level guide. As you are sitting on a chair, okay, and if you are sitting on this sofa, what is the difference between these two? Sorry? Cushioning. It means you are not much stable on a sofa. You are here and there. Okay, when you have critical area, like you have a 6 mm bone and canal is there, you want to place 6 mm of implant, then we are creating the guide on a bone layer. You open the flap, place the guide. So guide also rigid, bone also rigid, so you will get whatever what we have planned, you will get perfect result. Okay, so when we have critical area, at that time we are creating the bone level guides. Okay, like this, it's open the flap and you have to place the guide. Why we need this in case? Because if you go 1 mm down, then we perforate the lingual wall. Okay, so that's why in this case we have planned it exactly the same way and we got the result according to that. So in this critical condition, you can place, we are creating the guide on a bone level. So now we understand the disadvantage of technology and how we can convert it into the advantage. Okay, पहले था कि भाई flap test होता है guided. Okay, so but there is a problem. What you have answered already. What is the problem? So because of that, we have creating on the bone level. The same way, second one is you want already extracting teeth, so many sockets are there. You have to do a grafting, and in that condition also we creating on bone level. So like how much you have to graft, where to graft, everything you have idea before the surgery. And the same way, like you can see what the grafting and all we have to do. And this is the post-operative case. The third one is like a guide for the direct sinus lift. Okay. The problem only with the direct sinus is where to create window. और window करते 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 इतना बड़ा हो जाता है कि फिर ग्राफ डालना भी मुश्किल हो जाता है. And what level you have to do window? Okay, there is a two school of thought. Some of you have like doing the window at the floor of the sinus. Okay, और उधर ही ऐसे बर्गे. What we are following, like we are creating little bit 2 or 3 mm of window. So like whatever we are dumping it, it have a bowl to hold it inside. Okay, so for that we are creating the window and we are giving this guide. So like you can mark it. Okay, you can see the marking and then you can open up that window and do a grafting. Okay, so this is actually very simple opening, but the impact will be different. As last time I told, like the second inning cases are coming, so we have to use the implant for the supporting the guide. So in this case, we use the posterior to implant to support the guide. And in this, like you can see there is no ridge on the back side. Okay, if I do flap opening, it's very critical because all muscles are attached. Okay, to avoid the flap opening, we want to do flapless. So we use the anterior to implant to stabilize our guide. So on the reference of implant, we are doing the skylex. So this is the advantage we can take of implant, which is connected to the bone. So the question on back side. What is the difference between these two? Yeah, it is related. Huh? Any other option? Sorry? Any other? No. There is nothing. This is just how to away. Because I like what I am as a student thinking, like if I am not doing, I feel sleepy. क्या कर रहा है थोड़ा हाँ ये सब हो रहा है करके चलो छोड़ो करके और मैं अपनी दुनिया में रहता हूँ और प्रेजेंटेशन अपनी दुनिया में ठीक है फॉर दैट आई हैव केप्ट दिस लाइफ सो कॉपी से यहाँ पे लाने so this is the one more guide to place the zygomatic implants. It's my patent, Dr. Zygo, digitally regulated zygomatic guide. So in routinely the zygomatic have one lateral drilling and then you have the final drilling. So this is the first guide you have to fit. It will provide you lateral drilling. And the second guide on the top, we have a final drilling. So how it's work? So first we fix the guide on the zygoma body and the side. On nasal cortex we have a screw, second screw. Then we are doing the lateral drilling. So now we have a slot where we have to go. Okay. So you can see the after lateral drilling you can see the slot. Okay. The slot have a reference here. So your lateral drill will be stopped over here. So that much of bone only we have cut it off. Now after that we have one more sleeve on top. We screw it up. And then we are inserting the final. So exactly where we have to go, I will go and come out from the zygomatic body. So this is a guide for zygomatic implant placement. One more thing, like if some of the seniors are doing a zygomatic or seen doing a zygomatic is, you will not get a parallelism. Because I am a prosthodontist, first I will see parallelism. तेरा implant रहना रहे, मेरा prosthetic रहना चाहिए. So for that, what we have done it. We have developed a special tool. If you have noticed, there is one 42 is written and then there is a one flat line over here. Can you see? Okay, this is a marking and this is a tool. We have flat wall over here. Okay, so we have decided the position of implant hex because my multi-units follow the hex position for the direction. Okay, so we have already decided the position in software and we give marking. So you have to match the last rotation with the flat to flat margin and you will get complete parallelism of your upper knee. Then you have to take out the guide. Then what we have planned and the same case what we have achieved. Okay, so this is everything we can plan it before. So these kind of cases we can avoid the troubleshooting of the prosthetic. And one more thing, very interesting thing I want to tell you. Someone is doing implant. Most of the time we are doing treated implant or zygomatic implant, we get daily we are doing planning. So what we are getting, our patient is 40 or 42 degree, the sinus wall, visual, face angle, maximum time. More than 35, around 35 then more than 35, okay. And what our company is providing, their studies, like 30 degree, 17 degree, like that. So what happens, like if you follow the basic, like the freehand principle, like 35, my wall is there, so my implant going to be 35 degree. And I have solution of only 30. So I have a problem for the prosthetic. Okay, so this is the thing like we can do with the guided. We can plan the 30 and as much as possible we can take it back and we can avoid the problem. in that we have problem of fitting. In this we have only minor cantilever which can manage. Okay, so getting an active prosthetic, it's better to give minor cantilever. So this is the advantage of guided surgery. Any prosthomatic? Prostho. If I want to give a bridge, what you will do? Don't jump and you want to give bridge. Now my patient. Oh, sorry, ortho. Now is my patient, so I have to give bridge. What is your call? What will you do? Even interns also, if they are preparing the bridge or papers in Germany. You can create telescopic for this, or you can create finish line which will match this root canal followed by finish line. Both options are there to get the parallelism. Like way, these two options are there. Correct? Why I took it? You know? Because as the morning sir told, you should know your basic. The same way like basic roti, chapati, याद होना चाहिए सिर्फ जंक फूड नहीं खाना चाहिए. So now why it is not applied here? Can see this. जब आपको पता है कि ट्रूथ प्रिपरेशन में हमको करना पड़ता है because of like if I will place it here, my bridge will come out. If I place it here, it will come out. That's why we are preparing the finish line which is parallel. So why it is not applied over here? It is same principle. It's a basic. Okay. Problem सबको पता है, पर solution किसके पास नहीं? It's a basic. If you screw it up over there, what happens? This is my bridge only. If I am screwing only one screw on the deviated implant. See, this is active. Pop out. Now I have a scope like I can place it and screw it. So when I will press it, I have a lot of active force on that screw what I have already done it. Okay, why it's happened? Because of the finish and deviation. Okay, and multi-mills very mimicking some game with us like I am very parallel, but the top have 6 degrees of taper, but finish line is straight. Okay, when you place it, your framework is passive, but when you place the screw, it will become active because it will adapt to their margin with the finish line of the multi-mill. Okay, so this is the actual basic we should know like before doing any prosthetic work, and how to solve it. The basic question is how to correct. Any suggestion? Any suggestion?
Change the material.
Sorry?
Change
But
the
we
material.
have a last angle. We have already used from the company.
Customization.
Yeah, customization option, but what you customize?
Customize the option and data impression on
So
that.
sir, we have an option of customized multi-mill abutment. Okay, yeah, correct. So this is one you have one. Then second option. One more option is there. It's called OT equator. Okay, that is also prefabricated and customized. So it have capability to compensate up to 15 degrees. Okay, and the third option, if I have a tilted big wall, I have one more option. I can give a key and keyway. Correct? So this is one more option, key and keyway. But in tooth, I have PDL, so I can keep it separate. Okay, but in this, my implant is stable, so if I will keep separate, then it will act as a cantilever. So in connection, I have to screw to stabilize to create one rigid structure. Okay, and everything is passive. Now you see, I have selected this design for my case, what I have shown. So this is my first part, this is my second part, and then my screw will be there to connect the both parts. The remaining screw I have to do it on the implant. So now you can see. will screw it up first part. So now it is completely passive, it is not lifted up, and then screw the remaining. And then I have 5 screw hinges in case of 4. For fifth one is the connection of this EN key, the fifth screw. So now you can see it is completely passively fitted. So this is the post-operative of the same case. So now what to say about this? And this is very nominal case I am showing. Every day I am getting these cases, this kind of cases only. Because like someone has told like I am prostate, I can solve anything. So they place anywhere, wherever they go, they place the implant. Like that. So this is one of the example of that, which I am getting the cases every day. For this, we have created the second option, OT equator. What do you mean by OT equator? We have click like over tensor first, and then followed by the screw. So our advantage of click is it can compensate up to 15 degrees. So like if you have implant little here, it can compensate. Have you seen the ring? It is C shape, it is open. So wherever you have undercut, it is open. Okay. And the advantage is this. If you have multi-unit, it can compensate only 0. If 0 is there, it will compensate 0. If it is 17 degree and 18 is 70, it will have a degree of range. So this solution we can use it as a prefabricated solution. So we have used this equator. And this is the complete assembly for regulated implants. So this is a prosthetic. As I have told, because it will clip. So now it is stable without touching anything. And then we are placing the screw. So you have 2 locks, security locks also. If my screw got loosened up, it will not fall down like a prosthetic not moving and it will not affect my implants. And the most important advantage is like, have you seen your two-wheelers like you have a jumper and MTS, so you will have less jump. So you have the jumper at a connection. Okay, if you have lateral forces, it will convert it into the centric force and it will reach the implant. So very less lateral forces on the implant. So this is the one more concept you can utilize it. So this is a post-operative of that case. And the same way, like as I told, zygomatic, we have different angulations, so we can use the same solution, same trick, and we can use up the case. And this is the newer material, it's a bars PP, so it's very low in weight. If you have more height also, it's very low in weight. And it has a cushion effect also, so we give a dual advantage. One is cushion effect of material, so it will reduce the stress, then stress breaker, and then implant. So this is a post-operative result of this case. So now, what is the difference between these 3? Just obey one thing especially. All 3 are dentists and all are friend each other. And 3 of have same condition is boiling water. It's a digital dentistry. So now anyone came, what I mean to say by this? Any suggestion? I give a hint, boiling water. If I keep potato in the boiling water, what happens? Okay, so dentists who don't want to go in digital dentistry, वो मेरे काम का नहीं हो, उससे कुछ नहीं होता. Okay. Second one is egg. What happens if I keep in boiling water? बाहर से उसको ऐसा दिखाना कि मैं कुछ नहीं करता हूँ, और अंदर से वो डिजिटल डेंटिस्ट्री करना है. ठीक है? And the third one is like coffee. So if I will put it in the hot water, it will change the water into the coffee. Okay, so it will take the technology in its own practice. So now you think what you want to be. And I feel everyone have a high tea or high coffee right now. I hope. And the next is like telescopic denture and fixed prosthetic also we can plan it out. So it's you can see the different direction of implant. It's all different direction. So we have to make it straight, anterior and posterior we have straight, and then we fix it. So like you can see the abutment what we have modified. So telescopic have fixed and then screw return. So both advantage have on the prosthetic. The same way, after correction of multi-unit also we have deviation. So same we can give OT equator. Same technology. And the lower, the same case what we have, I was shown with the previously the guided placement. And our upper is planned because we have to place in kind of socket. So it's a planned surgery, like which kind of abutment we have to place it. Okay, even though guided surgery, it has a deviation in upper. But it is in our under control, like how much we have to cover after that. Okay, because we have to place all impaneled socket. So according to that we have planned. And lower, all are straight, so we have used normal multi-unit abutment. So this is a click, and then you are doing same way. Same bars will be prosthetic. And this is a post-operation case. And there is a first one with line, smile line, everything we have to follow. Right? And according to we have planned the previously. That's why I am showing this particular. So backbenchers, awake? Someone smelling bad, so I am asking them, awake ना? मैं तो सो जाता था, क्योंकि मेरे बस में करता है, मेरे को क्या काम है इसका? There's we have planned the same path of insertion, then it will be passive. Either you modify the finish line, either you modify the fitting area. What happens if I have this kind of breath? See the cross section over here. It's touching to my abutment first. Here I have a lot of space and then it's touching. So what happens once it touches, it will lift it for the other side. Okay, because of angle deviation. To avoid that, what we can do is we can create. This is the advantage of digital dentistry. What we have seen it, we can do it manually or whatever right now available. But this is the advantage of digital dentistry in which we can select the same path of insertion for both implants. Even though it is in different direction. This is now you can see it is not touching. When it's resting, it's touching. So this is the advantage we can take with the help of technology and we make it passive even though it has a different angulation. Like you can see, this is the thing, normally we are getting it all different directions, so we have created the cylinder according to that. So all have a path of insertion shape. So wherever undercut is there, we have space. In the same abutment, there is no undercut, we reduce the space. So we get the advantage of space in that. So when you are screwing it up, it will not lift it because it is already tied with the button. So this is the prosthetic post-operative. And so many things are there, but finally I'm just finished of this next year guide because like only I am speaking about implant treatment and prosthetic solutions some of them. And this is the next year guide in which we need a radiologist also in complete guided surgery. Like we want to plan the implant for the prosthetic, ear prosthetic. So and like we want to place the implant where my future ear going to become. Okay, so everything we have planned it. So this is the guide jig, like marker as we have using for denture. So only on the face we have only take is a reference point, the stable point. I can take a reference of tape to place implant over here, mastoid area. Okay, and this is a reference we have to by CBCT. And we place ear like which is a suitable position on it, and we kept the marker on it, and place this complete assembly by CBCT. So we have marker, so where in that area we have to look for the implant placement. So on the day of like we have planned implant on a position, and then we create the guide on that same jig. So on the day of surgery, we place the jig, we hold it, and then we doing the drilling. So after post-operative, like we place the implant. So now we have used a scan body and CT scan. There is no face scanner in it. We use a radio opaque scan body and scanner, and we got the position of our implant. We design the bar, and we trial on the patient. Okay, so it's perfectly fit. Then same reference we take it to get us prosthetic done. Okay, now we have two options. We have designed a prosthetic which is fitting onto the my bar. So either I will do a wax printing and routine way I can do a packing and creating the silicone. The second one is I can directly create a die, like a mold, male and female, and inner side is the outer surface of ears. Okay, so in this case we have decided to create the wax printing and convert it into silicone. So this is the post-operative same case. And when we feel we are good, like she done it because she want to get married, and we see the social media photograph of her like this. So she's enjoying her year, and just now, I think 4 or 5 months back, she got married. Then this is guided bone regeneration for the paleo. Like we can, before only we can create titanium mesh, how much the quantity of bone I want to build. Okay, we can calculate it, and you can see the post-operative already there on the position. And like if you see like Bhopal side is open, if I want to do a grafting, I have to take a plate from the ramus and stabilize, and then I will create a vertical height of the bone. So I have a guide like how much bone I can take it out and utilize it, and where to fix it. You can see over here, there is a line. Okay, so after removing the plate, in this area you have to fix the bone. So this is some of the guide we are utilizing for just for implants. So many other guys are there for surgery and all, but this is only mainly I'm talking about implants and solutions. So thank you everyone. So any question? I have question. If you don't have question. So like if I am among you, I will ask one question. Sir, clinic पे इतने रुपए नहीं है, तो if I will invest so much of money behind technology, then how I will earn it? Correct? मैं जो कमा रहा हूँ तो टेक्नोलॉजी को दे रहा हूँ, तो घर पे क्या लेके जाऊँगा? बराबर है ना? ये क्वेश्चन है कि नहीं है सब? मेरे को तो बहुत था. फिर एक दिन मेरी बीबी ने मुझे आंसर दिया इसका. How? Any guesses? She went to beauty parlor and got the hair coloring. Okay, and some 3,000 or 4,000 they have charged for the hair coloring. I don't know the exact charge, but around that. So she told like this is the I have spent it, and we have to pay this much of amount for the coloring. So I asked her like how much time it stayed. So she told me like around 6 months or 7 months more than that. So like they are ahead of us. They are doing that much of marketing that only 6 months is long last of that color, and we are paying 3,000 or 4,000 to them. Then our crown is lasting for 10 years, 15 years. Why we cannot charge them? So who is behind that? So this on that day I say yes, this is the answer. So whenever patient is so this much of money, then if female is there, then I will behind that makeup and all. Okay, if male person is there, then I am behind the share bazaar and this ring and all. So to answer them questions, and that you can do market. So this is the main questions like in all fraternity, like we should go with digital dentistry only. So as I told, शादी करना लड्डू है, करे वही बसता है, नहीं करे वही बसता है. तो कर दिया है तो भी उसके साथ जीना तो पड़ेगा ना.
Stop, I have so many of us, my question is that many of us, we do not have that guided kit.
Yes.
Because when you are using guide for removing of the bone is okay, but when you are using guides for placement of the implant, you would need drills with extenders. So how do you fabricate guides wherein we can use our regular kits which we have in our clinic, and still place guided implants?
See, to be honest, I will not suggest that a freehand kit for the guided surgery. Okay, what is the difference between that? Have you seen any guided surgery kit? There is a one drilling area, one is guide area, and then you have stand.
Yeah.
Okay, if you have a top to bottom drilling area, then I have to keep more play for your drill.
Okay.
Okay, because it will trim off inner surface of guide also. So there is a chance you will deviate like this or this from the start only. In case of that, you do freehand, you will get much better result. But if you are guided kit, okay, now one more my pattern is there. We are going to launch in January my own kit. In which you can same kit you can use a universal implant placement, like any system you can place with a single guided kit. Okay, on that you can do guided surgery, you can do bone expansion, condension, you can do indirect sinus, you can do socket seal with single kit. Okay, and like tensor bar also have one disadvantage, lower arch. Like if you have a thick bone, it will not expand. So our drill is different. Our drill is if you rotate forward, it will cut and it will condense the bone on the top, whatever you are cutting it. Okay, so that we have incorporated. And always why guided, when you are doing guided area, so as I told in starting, you are doing using a freehand surgery, drill. What happens? You are touching your bone and then you are starting the drilling. Okay, so you have, there is no reference because top also have to give space. If you have a 4 mm diameter of drill, then I have to give 4.1. Then only you can go inside and do drilling. If I give 4, then you cannot go inside only. So there is a deviation. In case of guided surgery, what happens, right? So your guided drill area, whatever may be, but your guided area is 5, then your inner surface of your guide is 5.05.
Yeah.
Okay, so there is less play. Now what is the difference? Some of them not getting a result with the guided surgery. Why? Because they are not following the protocol. What is the protocol? You have to do bone flattening, whatever may be. It is not like you are chopping the bone, you are just creating a duct over there for the lancet drill. Okay, you have to use a lancet drill. So what happens, like you have a bone, one drill in a bone and there is a guided area. Now you have to do 2.2 by 7. Okay, so when you are doing 2.2 by 7, your drill already inside of this socket and your guided area touch to the sleeves and do a drilling. Then 2.2 by 8.5, then 2.2 by 10. Then you have to go to 3.5 by 7, 3.5 by 8.5, then 10. So means you have two reference while doing the drilling. One is socket what you already have created in the bone and the second part is sleeves. So these two reference if you are following, then you will not fail, you will get 100% result. The problem is that people are using the guided kit also initial, then 2.2 by 10. So at that time what happened, there is no reference in the bone and they will like freehand only, like cross and they are going inside. So this is the thing, like how to use the guided kit is also most important part in the medicine.
Okay, thank you sir.
And like we are giving the guide along with the kit also, like you can use it and you can send it back to us. So this is the thing we can get it. And for the implant insertion tool, we have developed some special tools, like we have marking. So like we have multi-unit angulation, everything is calculated. So if you stop, you will get the same angulation. Like if you are using Jensen, then 15 degree, or if you are using Ostem 17 degree, like that already calculated. So we are not going to be multi-unit, we are going to do cement retain, that also like 15 degrees there, 22 degrees there, it is already calculated. So according to that we are planning. Okay, so we'll get more better result.
Okay.
Yeah, her question is like a screw got pulled well inside of abutment. Why? In cross section, you will face this problem when you using non-hex most of the time. And we are doing full mount also with the hex. Now we are getting a solution how we can get it. If you have, so if we have time, so I will have a 2 minute of when my apartment is there. So what happens in non-hex, like you have like this inside of implant, non-hex. Hex is like you are touching to the wall, to the implant, but non-hex is like this. So what happens, like your abutment is like this, also your frame is fitted and your screw go in cross direction and engage the implant. Okay, so because of that, the deep portion of the screw is attached with the implant with a different direction and the head is different direction. because you are forcing it. So it is engaged, but it will not come out because patient is every day is having the food, so it will उसको ऐसे धक्का दे के वहाँ पे cold well, ठीक है? Same way in OT equator, what is the advantage is like when you click it out, it will get the center, whatever the direction will be. If you are more angulation is there, so in place of C you can create half 70% also you can use it of that C, okay, and you can do it. So you will get a center, and in that we have a play like here and there, so exactly you will get a center of the screw, okay, and the screw is only secondary tend to be. Primary main it is elastic one, and this is not a elastic, it is a bakelite. Okay, so it will not like a over tension elastic, like it will, and you are not removing out also, it is fixed. And bakelite is like you have seen that frame packs like you can rotate it and you flip it, so it's a bakelite. In nylon, if you mold it out, it will not get that, but in bakelite, it will get that. So if any lateral forces will be there, it will come to an own position. So this is the advantage of the equator. And the second is like if you have a full mouth and you want to do a hex retake. Okay, so like which system you are using over here, implant system? Yeah, great. So Norris have aesthetic screw abutment in which it can convert internal hex to external non-hex, and it will connect it with a single screw. Okay, and so this is my patented abutment in which like you have only this base. Okay, you have a hex in the base, on the top you have a star like this. Okay, so we are converting hex into 24 direction. So if you have on the top, you can rotate your multi-unit 24 direction to get the parallelism. So it's a chair side customized multi-unit. Now we don't want to use a multi-unit, like how it works with a multi-unit like this.
So this is sir, any system you can use?
Yes,
internal hex, any system?
Any internal, Israel and Korean both system we have. So like this multi-unit will fit, and when you insert the screw, it will become one part. Okay, and then you have to screw it at the multi-unit on top, and your cylinders.
So there are two screws basically?
There is one, only two screws always there in multi-unit.
One is inside.
One is same thing. But I just want to show this because, like, example, you don't want to use a multi-unit. Okay, you have only two implants, and here there, like, little deviation in angulation. So what you can do is, you can place this base, and on top you can take non-hex, and you can screw it up with the one screw. So with implant it is a hex, but we can take advantage of non-hex also. The both advantage we have. Okay, so now we have a hex in a base, so your screw will be going center only. It will not go like cross. And along with that, on lateral forces, you have two person is resisting the lateral forces. One is hex, which is connected with the wall of the implant, and second is the center screw. In non-hex, only the center screw is resisting the lateral forces.
That is why the screw breakage.
Yeah, screw breakage is there, and screw loosening also.
What is the cost for this?
Sir, in January we are going to be now the registration are going on, so we will launch it, but near to multi-unit only.
Okay.
And one more option we have on the top. Cylinder also we have 2.5, 5, 7.5 and 10.
Okay.
So everything you can rotate and get the parallel. And this is 17, 30 and 45.
Okay.
So if you feel like you don't need to change the base, on the top only you have to change. 17,
so while placement of the implant, we just put the base.
Yes.
Everywhere
yes.
we put the base.
Base,
and
and
then
you
later.
can check it with the multi-unit. Where you have to modify it. And the second advantage I will just show it to you. This is a rotation, like routinely we get 60 degree only we can rotate. In this we have 30. And the angulation A from flat wall and B have an angle. So it have a 15 degree of rotation. And the third advantage is here. This is most common advantage, like the problem. Like if you have tilted implant, so if you place the multi-unit, the distal bone will interfere to place the multi-unit abutment.
Yes.
Okay, so we have reducing the MTQ. We are on a top state and then we have angle. Here it is that side.
You have burrs for removing that board.
Yeah, but the burr is there, but you have to remove the board.
That is
there is no need to remove the board. And the third advantage is if you have gums over here, by chance they will recess. In this it is completely attached with this. Screw is inside. So no lodgement, nothing, like it is attached. And by chance in future if your small screw got back down, no need to open this multi-unit, just you replace this cap. So you can get the prosthetic. So this is the thing. So anything?
Yeah, I would add, no? Anshul talks about guided surgery, but Anshul will give you prosthetics wherever you put your implant, whatever angle you put, he will give you a solution for it.
Because we have two kind of people. I am good in free and I can place implant. So for them I have a solution. If you follow my guided protocol, I have this solution. And the third point is like sometimes we have bone compromise. So we have to intentionally place the implant, but we should know what solution I am going to give to get the prosthetic. So this is why we have created this thing.
Sir, in that case you are again making a weak link again. Like that you are making weak link because the particle, the cross section will be very thin. In future it may fracture also.
Great question. I want it will fracture on that section only. If my lateral force will be there and if I have a regular multi-unit, my screw fracture inside. In this, my screw fracture outside. So I can take out the base and take out the screw. I have a disc, like tail is outside. Okay, from weaker link, I have to fracture my, like I want to fracture it. Okay, so this is the end. The third advantage, my screw is not what normal multi-unit screw, if you see, it's very thin. This main screw compared to your regular screw. Okay, so what we have done is we have here double head. Double head. So the normal head is what we are giving a normal screw. There is one head. The second head you are getting with the multi-unit head, like in the base, that it is like this, and then your tail will be sharp. So the weaker link will be resisted by that double head inside. So it will not allow into movement. And this is calculated value. It is 30 microns, like how your abutment with the implant. The same way 30 microns difference only there. So it will not move easily. And then you will open up the screw. And if we get fracture, it will fracture on that link. So just open up top portion, take out the base out, and then you have a screw tail. So you can hold it and take it out. So everything is keep in mind and design it.
Thank you, sir, for guiding all of us. Prosthetic outcome should always be taken into consideration first before placing the implant, and also it will be easy for us to explain the patient and grab the patient. Thank you, sir. I request Dr. Siddharth Gupta sir to please give a token of appreciation to Anshul sir.
I just want to announce that according to the earlier program, we had a workshop which was scheduled to be done by Dr. Anshul, but due to some unforeseen reasons, we are not conducting that workshop tomorrow. So instead of that workshop, Dr. Anshul will be taking one more lecture tomorrow. So this is just for information. We will be letting you know the schedule and the timing for Dr. Anshul's second lecture tomorrow in the morning itself, so that you can make yourself free and be here to listen to him further.
And in that lecture, like it's like department. भाई OMDR में क्या कर सकते हो, एंडो में हम क्या करते हैं, और सर्जरी में हम क्या क्या करते हैं, with the disease. So like you can see your scope. There is a scope of disease dentist.
Now, the time is approaching for the lunch. I request all the delegates to please gather at the front side of our college. We'll be back at 2 p.m. for the next lecture. Thank you. Today evening we are organizing a banquet night, so anyone who are willing to come with us, we have bus here available. We'll leave on at 6 p.m. sharp. 6:30 p.m. sharp.
Can I get the maximum? बटन दबा दो सब तो सिग्नेचर का कोई दो पेशेंट है आई थिंक दैट 6000 चल रहा है 360 yeah कम मिल रही है 360 ज्यादा है and the other is the student 8000 में चला 2000 सही चल रहा था first one not Mevla he had some lesion no he got a lesion so what you do is you just put 35 and 36 I've already done on planning. Yeah, please see. Please help me. He's tired of calling me, telling you do this, you do that. I said no, I do so many things. He's concentrated on guides. And he's amazing. What a guy fallen for and all. That's why I always tell you, we both are talking. Anything in a straight line, you come to me. Anything which is around you want to do. Actually, is the best person. Yeah, safe. Face can easily come in. So 3D printing I did. Therefore yesterday I did it, so I just put it in my suitcase. For the doctor only I went and I have to give it. I should not forget. What the key calls, that's why I have to check it. That's a patient specific for glucose cases. Designer printer. He's a designer. which we're going to plan, Anshul is going to plan on how do we place an implant. It's a static guided surgery. So he's going to plan implant, and then he's also going to generate a surgical guide, and then I'm going to take over and then execute the guide using a 3D printer. Here you can see that the entire set of 3D printing setup is here. It's a small setup. Today 3D printing setup doesn't require a huge space. It's a small space. A table space is what you require to set up a 3D printer. So what we're going to do is we're going to print out a surgical guide, and when the time when we are going to printing surgical guide, there will be a small presentation by Bioline, and then I will take across on a little bit more on 3D printing. Let us go a little more deeper into 3D printing. What is 3D printing? How do we adapt it? What do we buy? What not to buy? All those things we will discuss about it. So this is my schedule today, and tomorrow we will see about the CAD and other stuff about it. You as youngsters sitting here, at least from not in the first row, second row onwards, I think these statements have to be ingrained into your brain. Dentistry is no longer a static world. Dentistry is no longer a very stable field. As today I have learned, and for the next 20 years I am going to be in the same world. It is not going to be. It is a very, very dynamic field today. What you learn today, tomorrow you will have to unlearn itself. If you don't unlearn, you're not going to relearn it at all. So you have to keep your mind open. You have to keep your concepts open, and there is no concepts today. Me being a prosthodontist, we've all grown, our whole prosthetic textbooks is all on concepts. It's all on theories. We talk about one particular theory, another particular theory. D1's statement is being told, it is being purposed today, but there has been a change in what we are thinking. In analog dentistry, we took, complete dentures. A very typical example I give in my presentation is a complete denture. When we talk about preliminary impressions or secondary impressions, all of us, at least in the first row, all of us have done impression compounds. Impression compound impressions. I'm not sure the other behind people have even seen impression compound. Maybe in the first year dental materials they must have seen impression compound. After that they have not seen impression compound. And it took us almost 5 decades from impression compound to silicon impressions. And believe me, it only took us half a decade from silicon impressions to digitization. So just imagine, from 50 years we shrunk to 5 years. So the world is very, very dynamic. Dentistry is ever changing. Today what you read or what you learn in the textbook today, tomorrow there is a new concept which is coming there. But I don't mean that every concept which is going to come is going to be continuing and it is going to be there, but we need to know, we need to be there. That is why I put this statement is that our workplaces are changing and the changes are quite dynamic. We as professionals need to pay attention and prepare us for the future. An important aspect of preparation is to develop the skills that will help succeed and thrive in the new reality of the next decade, or the new decade. I don't call it the next decade, but a new decade. These are going to be the most important job skills for the future, and there is no better time than now start building them. So this is the statement which as youngsters you need to look into in your post-graduation. When you are doing your post-graduation, this is a golden opportunity. You know what? You can do a lot of mistakes here, you can learn a lot of things here. But you don't have the same platform when you're coming to your private practice. Every mistake you make is going to be magnified. It's going to be bad for your practice building. So this is the right place for you to learn. That doesn't mean that you make some catastrophic mistakes here. Means is you can learn. You have a place to learn. You have your mentors to learn. You need to do it, and today is a field when you start thinking about it, you start implementing into it. I'm so happy that, when Anshul told me that in morning when we were sitting here, we traveled together and sitting here, he said, sir, I think it's 2012 when I saw you first. I didn't realize. I think, yeah, it may be Anshul. So I'm so glad that I could put a spark into him. And I'll be even more glad if I can put a spark to a couple of people here and they start looking into their career and into the digital world. So digital dentistry is no longer a buzzword. It is not a fancy word to call in Google to say digital dentist. I'm a digital dentist. I've been doing this. It is no longer a buzzword. It is a reality today. Digitization of dental workflows have provided quantifiable benefits in terms of quality, time savings, and labor cost reductions. And this is not just a statement. There are enough publications to show that these are the realities which you are doing in your practice. You can see that. See the impact of digital technologies onto your workflow. You can see that it is not only about, it's not about economics, it is about quality. It is all about quality, it is about precision,
It is about predictability. Because, see, these are the basic three tenets of digital dentistry when I talk about it. One is the quality, precision, predictability. These are the three things which you need to think about. This is one of the basic tenets of dentistry or digitization we need to adapt in our lives. Because everybody needs, which is predictable. Nobody wants to become a guinea pig. You just imagine, you want to sit on a dental chair for a guinea pig? No. I want it to be something predictable. I want something to be precise. And I want something to be workable. So digitization is giving you a third eye in medical and dental terms, wherein I can look into what I want to do before. I plan the pluses and minuses of it, and then finally I can do what is best for pluses and minuses of it, and then finally I can do what is best for the patient. So this is what digitization is all about. Digitization is not just doing intraoral scanning. It is just thinking on how do I proceed with this case. There are two examples I would cite when I'm talking about this. One is, all of us, thanks to COVID times, we've all become, addicts to OTTs. Right? Netflix, Prime, and Koreans. Korean drama has become the flavor of India. All of us would love to watch Korean, umpteen Korean movies. And there is one Korean adaptation called as Good Doctors. It is a binge watching for me. And you know what? In, I think season 3 or season 4, there's an episode 10. It's about digitization. You know what it does is, they're going to do the doctor is going to perform a very complicated surgery, a heart surgery. So they want to know what is the type of incision they can give to open the aorta. So what they do is they digitize it and they do a virtual planning. And they do use VR, a virtual reconstruction, and then they start doing it. And he puts a incision, he puts things, and you know what he says? Okay, I'm doing 10 mm of incision, and he says patient dead. He says 8 centimeters, patient dead. So he says 8.5, patient is alive. Where do I put my incision? Everything is earmarked. And I had the pleasure of attending one of the congresses and giving a lecture there on virtual reality and augmentation in medical and dentistry. This was organized by GSL Dental College a year back. And you know what? All of a sudden, my friend called me, Sunil, called me and said, Shiv Shankar, I want you to speak. There are no speakers on dental inside this. I said, boss, I have not heard about visual. I have not had any experiences as first-hand as virtual reality, and I've read a lot of book and literatures on it, but I have not had. He said, no, you should give us some presentation so that, I'm a dental college and I'm done, and 99% of my speakers are medical guys, and I want a dentist there sitting there and talking in front of the panel. So I had to happen there, and the presenter previous to me ended the presentation by giving a very good quote, which really pricked me into thinking about it. He says, patients will start asking you, did you VR me before you come to the OT table? In the sense, have you seen a virtual reality of me? Have you seen the virtual reality of an operation? Have you seen an augmented reality of the operation, what you have done? And are you sure that it is going to work? Are you just going to do a blind? No longer any surgeon today is going to go blind. And you know what, in my terms, maybe today it may be a little augmented way of talking, is that it is a crime for us to go without a augmentation. Without an augmented looking into what is going to happen, a surgeon go to the table, I don't know what confidence they will have it with this virtual reality coming into the picture. So this is what is the future, the way we are looking into medical or dental. We're looking into endodontics, we're looking into we're looking into prosthodontics, we're looking into guided surgery, we're looking into endodontic canals, and we've seen Dr. Neera gave a beautiful presentation on virtual guide. You can see that navigation, you can see how the drill goes. And every time the drill goes a little off, it gives you a red beep. Every time it goes, and it is not 1 millimeter off, it is 0.01. That is the precision and predictability what we need to look into it. So this is what digitization does. And this is what the impact of the workflows, what you look into digitization. There is a lower need for rework and perceived quality. There is labor reduction of up to 30%. And there's a capacity which can increase up to 50%. This is what is the reality. Now you can tell me, sir, economics, is it really going to come down? It is not a straightforward answer to tell you that, okay, I have adapted digital technology is expensive, and how do you say it is going to be economically work for me? I say, when you're talking about economics, it is not just about the price of a scanner, price of a thing. It is about holistically what I'm looking into it. Time is money for us, right? How much time do I spend on my patient? If I'm doing a prosthetic work, If my impression is, I take an impression, analog impression, send it to a lab, and a lab after a day calls you and tells us that the cutting was not good, the model has not been poured well, you've lost 1 day. And you're afraid to call the patient back and come back to the clinic. So you have lost a lot of time. It is time, energy, money for everybody. Whether it's you or the patient. Your chase time of half an hour he blocks, you've lost one patient. So it's like that. So it is when you're talking about labor costs, I'm talking about that kind of a costing. I'm not talking about a particular cost when my scanner is going to be 10 lakhs and how am I going to calculate per impression cost. Per impression cost is definitely going to be on a higher side. But you just look into the whole gamut of it. The whole gamut of it says that 1, 2, 3, 4, 5 steps. If I divide in these 5 steps, then automatically my cost is nothing. It is a nil cost which is going to go into it. So these are the things which you are looking into it. So for me, what are the benefits of digital technologies? The benefits of digital technologies is communication and visualization. I can visualize, I've already given you examples. I can visualize what I'm doing. I can want to see everything there. Communication. Now, today is the world of communication. Everybody wants to take selfies, everybody wants to take photographs, everybody wants to do geotagging. All NAC accreditation people want geotagging. Right? They must have taken already a photograph of me with geotagging saying that we have to upload it on the NAC website. That is because to know that this is the day it is. So we need communication. What is this? It is creating communication. So communication here in dentistry is that we are not just two people. We are not patient and dentist. We have another third person which is a very important person which you all tend to forget. The dental technician or the dental technologist. So we need all to be on the same table. So if we need to be on the same table, we need to communicate in a proper way. Communication is everything. Even between a husband and wife, if communication is not good, there is a lot of trouble. So communication is a very, very important tool. And digital dentistry is what it helps you in communicating what you are thinking. What do you want to know? What do you want the prosthesis to look like? And at the end of the day, you are giving it to the end user because the end user is a person who is the ultimate boss to all of us. If the end person is not happy with it, none of our pockets are going to be happy. We may talk all big, big things, but if the patient is not happy, it's like, what? Surgery went on well, patient dead. So that should not be the reality for us. We should know, we should be the same because the expectation when you do a smile design, I say I'll do a smile design, the patient's expectations tomorrow is to become, Alia Bhatt, Aishwarya Rai, Madhuri Dixit, whoever it is. But it is not so. The reality is not going to be that way. Reality is going to be something else. So we need to show them what it is. So communication and visualization is very important. Second thing is improved quality. When I talk about quality, it is about the precision and predictability. And I'm doing a prosthesis, especially when I'm doing an implant guide or I'm doing a prosthetics, a smile design, I need to know, before when I'm planning, I need the exact way it has to complete. Because otherwise, I have to get back to Anshul, saying that Anshul, give me your invention of a 6 vetter or a 12 face multi-units. You know what, I'm not telling you that it is wrong, but if we can avoid it, why not we can? Because we give prosthetic. I know there are some doctor who asked me about the screw breakage. See, if we can plan in before and say that I can avoid screw breakage, that is the best thing. So these things are about precision and predictability because the patient also comes to you with that expectation. See, you want to buy something, you go to Amazon and you see that I want to buy this, then at the end of the day you scroll and see what is the warranty on that. So it's the same thing. Everybody, whether it's a health structure or other things, everybody wants some peace of mind when you're doing it. So it's about improved quality and precision. And the third thing is archiving of data. Data is the king. I think I must have used the same term last year also. Data is the king. You know what, today, people who have money are not the richest guys. People who have data are the richest. Why is Facebook the richest guy? Why is Google the most richest guy? Because Google tracks you everywhere. Our mobiles, our where we walk, our watches, everything is tracked by Google. No? Every step you keep out, Google is tracking you. So they are selling your data to somebody else. That is because data. What is the food you like? What is the food you ordered? What is the flight you used? You just go to an online website and you want to try book a ticket. And from tomorrow, if you see, whenever you open anything on Google, you'll find pop-ups of flight charges, hotels, restaurants, everything. So it is data. And for us in dentistry or medical, data is again a king because data is a mirror for me. No, we are not gods, we are human beings. Everybody can make mistakes and will do mistakes. If anybody says I don't do mistakes, hats off. Because it is not easy. All of us are human beings. We are what we are. But the greatest guy is a guy who can look into their mistakes and learn from those mistakes. And data is what is giving you that. See, every time I look into a case, I go back and say, oh, I did a case like this, let me look back the photographs of it, let me look into the digital scans of it, and let me see a mirror. See, it's a mirror. It shows you where you are, how did you do it, where did you do it, if you have gone wrong, where did you go wrong. Then I can, I can look back and I say, I will not do the same mistake here. Let me approach this case in a different way, because if I approach in a different case, I can work on this way. So that is what is archiving of data. Now the fourth one is enhanced patient experience. Patient is the king. Why do we go to a 5-star hotel? We need experience. We need aram se. We know that the chai given by a chai wala is 10 rupees is very good compared to the chai which I am having it in a 5-star hotel. It is shitty tea. I still give 250 rupees and come out of it. Just the ambience. I give the money for the ambience. So your practice is also the same. The patients are going to pay you money if you have the ambience to do it. So it is the patient's enhanced experience which is given to the words in digitization. Now let us look into digital workflow. When we talk about a workflow, because see, Anshul also during his presentation, or Dr. Neerav also in his presentation, talked about a workflow, a standard operating protocol. We call it as an SOP. Everything has got a path. Even when we are stepping out of our house today, we are coming only with a GPS. Even though I know a route in Bangalore, I will never venture out without a Google map. Because I want to know when I am going, where I am going, how am I going, what is the path I am going to go through. So it is the way it is predictable. So you need to have a workflow. If you need predictability, you need precision, you need a workflow. If you are not going through a workflow, you are not going to get predictability at all. So you get out of your house, I may come in 10 minutes or I may come in half an hour. Today no longer that answer is valid. So I need to go in a proper way, I need to do it. So when we need in digitization, in the morning I was talking to someone else that, you know what, analog dentistry is forgiving. You can get away with it. Digital dentistry, my dear friends, is not forgiving. It is totally an unforgiving science. Because one small percentage of error which you incorporate in your digital scans, by the time it comes out to your crown, it is almost 50% it is magnified. And you are at loss. Where did I go wrong? I have nothing to refer. So you have to be very, very clear on your flows. So what is the digital workflow? When we talk about digital workflow, we have three terminologies in our workflows. One is the acquisition of data. We need data. Like we take an impression for preparing a model, we need a data. Data is everything. We need either CBCT or an intraoral scans or a CT. Everything is acquisition of data. The second one is your design, the CAD design. Whether you do your crown, you do your implant placement, you need to do a design. You need to get into the software, start working on the software, visualize the end product, and then you finalize the end product. And once you finalize the end product, you need to produce it, because you cannot just stop at doing design. You need to produce it. At the end of the day, you need to fabricate it, whether it's a surgical guide or a crown or a bridge, whatever you name it, you need to produce it. So when you produce it, it is called as a CAM. So these are the three technologies which you are involved into it: acquisition, design, and the CAD. When you talk about CAD or the acquisition of data, we can acquire data in two ways. One is a direct way, that's an intraoral scan, and there's an indirect way which is going to be a model scans. So you can look at just a brief way of what it is. A representative of an intraoral scan, you can see it's a real-time representation. There are, I think, 1, 2, 3 scanners on the exhibition booths. All of you guys can walk in and try. I would say it's a golden opportunity for you guys again. You know what, it's not so easy that all three fellows are standing there and you're going to handle these things. You can handle all these things, and you can see that this is what is the reliability which goes into it. It gives you the communication. See, instantly you will come to know that this is what is there, how it is there. It's a real-time representation of what you're looking into it. This is what intraoral scanner gives you the advantage. Once you do this, you can visualize it. See, today we have, you know what, all the intraoral scanners have an analysis called as restorative analysis. So where we know how much of tooth preparation is done, whether the clearance is good, whether the clearance is not bad, whether there is undercuts in my preparation, everything can be analyzed before you send it to the lab. So you know what, you're not asking the patient to come back again to you, because you are doing your own self-check, quality check, and sending the patient out. or even the worst case scenario, you're not able to visualize it, you just send it across through a WhatsApp or through an email to your dental technician, and dental technician can see it, and then you can make the patient sit outside in your clinic for 5 minutes, and he will be able to tell you whether it is good. Then you can send the patient so that there is no lag of time for you, or the patient does not have to come back to work for you again. Now you can see a laboratory scanner. A laboratory scanner is a scanner which scans the model. It is, it's just a model. You can take an impression, pour a model, and then the lab does this. The lab puts it on a scanner, and then you can see that the whole model gets scanned, and you get the same data what we require. Only thing is here you need to do a little bit of digital work, analog workflow, where you need to pour a model, cut a die, or you have to do a ditch of a model. Then only you get a correct representation of what it is and how it is to be done. Then once the plan is done, then you do your design. You need to do a design. If you are doing a CAD design, you use softwares. There are different softwares for different processes. Not one software fits all the workflow. You have different software. For example, if you are doing a crown and bridge, you have different software. You need to do implant processes, it's a separate module. You need to do smile design, it's a separate software. You need to do surgical guides, it's a different software. So there are different softwares which you work on it. Now when you look into the software, this is what you look into. See, this is magnified. You can look everything, where your margins are, how your margins are. You can see the margins, and if you are looking into color scans, you can even know what is the difference between a gingiva and a tooth. How you've done everything is visualization from part of it, which is going to be there, which is going to help you in the precision and predictability. When you're looking into precision, you're looking at everything is parameters. We have, when we select for example, if I select a crown, the software is not just going to allow me to go ahead with just a crown selection. It will ask me which material I'm going to use. What type of a crown are you going to make? And if I'm selecting the material, then it will tell me what is the minimum thickness of the material. What is the cement spacer of the thickness? Everything is taken care by it. It will go step by step, it will go step by step. So I need to fix all these things. Because what happens is, we have this habit of, I do something on a machine, it fails, I am not to be blamed, machine to be blamed. No, we are happy, no? Even in our life, if something goes wrong, I will never accept I have gone wrong. I will say that. I will find people to find where am I going wrong. So that is why software will not allow you to go. It will give you a red signal. It will say, boss, you're not going in a right way. He says, shut up, I will go on my way. He says, okay. You are my boss, I am not your boss. So it is there. So that is what it is going to be there. You can see that. You can check your occlusion. You can see your contact points. You can develop occlusions. You can check in cross sections. You can see minutely how you can do an occlusion and how you can work on these occlusions and done. So you can also do crowns. So you can see that. You can see predictability of a crown. Here you can see that the crowns are milled out of it, and then you can glaze it and you can finish it, and then you can do it. So once you've done this, you need to produce it. How do I produce it? Today in dentistry, we can produce crowns or bridges or surgical guides, anything we talk about, in two methodologies. One is a subtractive methodology and is an additive methodology. Subtractive is an age-old technique, wherein we put a chunk of material and the machine carves out whatever we want. It's like a sculptor. A sculptor takes a stone and then starts using a chisel and then sculpting out what he wants. Whereas an additive manufacturing is a manufacturing like building your house, building a brick house. You go brick by brick, brick by brick, brick by brick. You cannot just go one concrete block and then put it there and then you say my wall is done. Of course today we are doing that. But when you're talking about it, you're talking about brick by brick. So this is why it is called an additive manufacturing. And the world is moving towards additive manufacturing more than subtractive manufacturing because primary reason is that we save a lot of material. You know what happens when we are doing subtractive manufacturing? Almost 30 to 35% of the material is just going waste. It is just going into the drain. Whereas when we are talking about additive, it is only around 8 to 10% is the wastage which is there. So we need to do it. And then when we are doing additive, we can do a lot more things. Because milling a certain thing is not easy because you should understand that when you are doing subtractive, it's got a tool and it's got an axis which moves. So you're only going to a certain extent, it cannot go anywhere. When I'm doing my additive manufacturing, whatever I want, I can do it. See, if I wanted to print a skull here, I printed a skull in 3D printing or additive manufacturing. Let us say, if I want to do this in subtractive manufacturing, it is impossible. Because you know what? It cannot go into these crevices and then start milling it up. Even if I want to mill, I will have to have a machine which is 2-3 crores of rupees, which is going to take at least 25 to 30 hours to do this. Whereas I'm doing a printing, this probably takes me 2.5 hours to do it. So that is what is the difference between additive and subtractive manufacturing, and then additive manufacturing is tailor-made for dentistry. You know, additive manufacturing industry is woken up because of dentistry. It was a sliding phase, because what happens in additive manufacturing is you cannot do mass productions. You can do precise, crisp, very, very precise, precision printing, 1, 2, 3, 4, 5. More than that, it becomes a very tough situation. So if you want one of a type, it is very, very difficult to do with additive manufacturing. But of course, today they are also doing those aircraft engines are additively manufactured today. But you know, in dentistry, because we are doing crown, no? We're taking a small part. And we're doing very, very small, precise parts we want, and we want only one. We don't want 10 numbers. We don't want prototyping. So that is why additive manufacturing is tailor-made for dentistry, and that's why dentistry is just been in love with additive manufacturing, and we just jumped into that. What is this additive manufacturing or 3D printing? 3D printing is a process, I've already told you, no? It's a brick by brick. So it's a process of making a physical object from a 3-dimensional digital model, typically by laying down many successive thin layers of the material. Material can be anything. Even houses are getting 3D printed today. Instead of resin, you put concrete into it, it prints. So that is what is the technology, what you're looking into it. In dentistry, we use all types of material, all types of printers. Whether it's a wax printer or a resin printer or a metal printer, everything we work. We use everything. Wax, resin, as well as metal printers, we are using into it. And what all can we do? We can do typically whatever we want to do it, we can do. You think about it. Imagination is your limit in 3D printing. You can imagine it to do something, you can definitely do it. You just need an STL file out of it, you can do it. So you can do, see, dental models, surgical guides, temporary crowns, denture bases, denture teeth, removable partial dentures, indirect bracket trays, your complete denture trays, gingival models, splints, mouth guards, castable crowns, implant prostheses, temporary crowns, permanent crowns as we are talking. Everything can be done today. Everything which you can think about in a way you want to look into it, you can do into this whole kind of a workflow what you are looking into it. Now when you're looking at types of printers, there are different types of printers available in the market. One is typically a resin or a wax printer, another is your metal printers. So what I will do is now I will stop here, and then once I will tell, I'll let Anshul take over, because I will not, once I take here another half an hour, I will not be able to stop because the flow will go. So what I will do is now I will request Anshul. We will do a case present, a surgical guide. I think this it's a student of the same college. So when Dr. Anshul was doing his presentation, I went inside there and then I did the scan. I did an intraoral scan of the patient. The CBCT Dr. Prashant Jaju had already sent it to me a couple of days back. So we have now taken the CBCT and we have taken a DICOM data and we have taken an STL data. STL data is intraoral scan of it. Now Anshul will take over and then he will take you through the whole process of how do we design a surgical guide, how do we plan and design a surgical guide. Anshul, it's yours. Off these lights. Off.
must be there. The other one,
Yeah, so as sir told, like we need a internal scan or we can take the impression through the cast and scan the cast. Okay, so we have a, why we need this? Because in CT scan we don't have gums. Okay, and we require gums because we are doing the fabless in this case. So that's why we need the records of the internal as well as CBC data. And in internal record we don't have bone, like how much the depth of the bone, how much the width of the bone. So that's why we need a CT scan. So CBCD data. So that's why we have two data. So we have to work on it. As you can see in this, like this is a missing on a fourth quadrant. 4, 5, 4, 6 are missing. So we are planning for that. So we just check it out which data are missing, and the same way we are checking it out the data of the CT scan. What we have opened it up. So as in morning I told, like we can scale it. We have an option to render it. This is the face, like outer face of the same face. If you have complete face data, actually face scan, then you can see the face also, nose, eye, everything you can able to see. Okay, so this is outer of the that face, and we can rendering it out. We can reach with the bone. Now this is my bone data. How I get? So it is like a clean data I have. So I can see, like I can place on. So now I am wearing my gloves and starting my surgery on PC. Okay. So this is the thing, like, so like as you know, like we have a missing tooth. So I have to first write down the client name, like the patient name and doctor name, whatever the case is there, and then I have to start my thing. So as I do, like 4, 5 is missing, so I'm just clicking on 4, 5. Just right now I don't know which kind of implant or which kind of prosthetic I'm going to do. So just I'm just selecting right now the implant planning. Yes, so I do have Bhopal library. I have Austin library, so I can go to that. But yeah, not there for example. They have only prosthetic library. So right now just tentatively selecting the material because I don't know, I can select later on also, I can change it also. Even I can select it also if I feel like I have to place 4, 6 and 4, 7, I can change it also in between. But tentatively I have to give my software because software is working on that data, so like that according to that it will give a command next to next. So same way I'm just giving on 4, 6. And I'm going to save my this data command. So now I'm planning 4, 5, 4, 6 for a particular case. So if I click on my implant planning.
And the software what Anshul is using is called as an exoplan.
So we have different software in which you can plan the implants and then so we are using this because it's connected with the exoplan. So like you can plan the prosthetic together if you want. And we have a library in which like we can see the abutments also. So like according to company abutment we can plan it. So as a start, like you can see the select the CT data, means software is asking the CT data, so you have to put on the CT data.
Sir?
Yeah. So you can see all the data what given in while CBCT, like we have an Excel view of CT scan and this much of slice number in 5 images are there. Our data. now I have, that software is asking a different render. So I right now selected soft tissue, so I have to just do a soft tissue and default. Then the bone I will modify because I need this is good. It is not mandatory like how much you do. Just you can able to get a clean surface, just you go through it because after that you will get a resolution radiopaque data also by your time, as we have seen in this kind. So both together they are working. Then this threshold, it means like you have to mark the cortical area, like how much the cortical area around. So you can see all the dense bone. It will show you dense bones, and this is a porous bone. So you can see the threshold upper. Why? Because sometimes you don't have bone on the top. Can while planning you cannot see regular, like so sometimes we have big trabecular patterns are there. So you feel like it is open only. So if you using this view, you can plan it out. So you can just see where is my heart and you can plan it out. The next is we have to set the plane. So there is my implant. I'm going to plan it. So I'm going and I'm set. I'm going to share the So I'm just setting it in the center of my crest. Now we have three different options, like as I told in morning. If we have edentulous case, then we have denture. So like we can do a CT scan of denture. And we have two data, CT scan to CT scan, we have to match. Okay, the first one is like as we have told, like intraoral scan and CT scan. So in which like we have a like intraoral scan with the gums, and another one is a CT scan. So we are selecting right now. We have this option, and third one is like I don't know what I'm going to do. Just I want to plan it. If I able to do a place implant, then I will take impression and further thing I will do. So that's why there's a three option on this stage. So right now we have this option like CT scan and can go to that. So now I have to give a data of intraoral scan. So now as I told in morning, we have only tooth is a reference. Okay, so you can see the tooth in a CBCT and tooth in a model. So we can superimpose together as a with the help of this teeth. I'm marking the third point as closely as possible. So like we have all maximum data we can superimpose. So now software start mimic. Now we can check it out if it is good or not. You can see on all cross section. The green color what you can see is a cross section of the cast. You can see here there is a gums and a bone. If I will hide it out, see you can see the thin gums in the CT scan over here. And then if I open it up, you can see the cast. So now almost is matched. Still software is trying to get more nearby and is adjusting it according to that your final result. So in this we have marked the 3 points, but sometimes we are not clean the data. Then we can clean the surface also. Then we can completely select the surface and we can superimpose. Like we have molar ground, so we can directly paint the molar ground. So like software is trying to match. Right now software is trying to match the data which is common. You can see that now it's, if I will see in this cross section, it's not matching perfectly. You can see in this cross section. Now it's like, if you can see in this, like it is literally offset on this side. So you can go back and we have a mark. You can paint it, the surface you want to match. I'm not marking on Ginja because it is not very specific. Now you can see the first one mentioned. Going on this side.
नहीं जो ये चीज़ अभी रिकॉर्ड हो जैसे अभी नॉर्मल जब लेक्चर चालू होगा फिर रिकॉर्ड कर देगा रहता है वही.
So right now I don't know like which kind of process is going to, so I will keep it later on. And now it's now place because we are planning on a ground, so I will take it over here and check it out. Dimension we can see the antenna. There is one defect over here on the back side, so it is mimicking nearby now. You can see there is a defect. So we are not planning. Our plan is going to be finished before that also. So I do not require to mark continuous. This onto the no, just then if I want to do a twin alignment, I can do it according to implant. I can plan it. If I have antagonist, I can call antagonist and use the proper approach. Now CBCT is open, so I cannot say it's a perfect result, but I will try to like my future crown going to be somewhere over here. now I have to select which company implant I am looking for. So like example, I am using the steps and I have to select and start the white tag and then I can modify the size, whatever I want. And this is I have selected for 4.6, so I will just take it and put it on 4.6. So now this is the thing actually. Yeah, this is a good arrangement I have done it. See, if I will place it on the center of the bone, then I am more lingual to my tooth. So this is the more advantage of having a digital. If my future occlusal is going over here, and I am placing my implant exactly in the center like this, I have a scope, I can place it like this also. And if I will freehand, if I am doing, definitely I will place it over here. Okay, so this is a minor deviation, but it helps us a lot. If you see, it's going on a lingual side completely. And it is opening on lingual completely. So if I keep it like this, yeah, so I can near to my center of my implant. So this is like most of the people like a single connect other products. But single is more helpful than full mouth. Single is more helpful than full mouth. Okay, and if I want to see like abutment what I have, then I can use my tie base or like so this is a pre-mill abutment, I can use it. So it's giving me a scan body in a layer electron. Then I'm jumping onto the plant part. Now it's going time is pre-mill. But I have a library in Sweden in which I have a time base and everything. So now I have a tie base, so like I can go to the tie base. You can select a tie base. So I can see my abutment also in my plant. Like it's my tie digital abutment, so I can see the abutment. If I have a stock abutment, I can see the stock abutment also. Like in this, we have a limitation of straight abutment only right now, so you can see the straight abutment. So according to abutment, we can plan it out. So we have a 3 mm height and 5 mm. So now, right now I will use 3, but I think we can use a 5 also because we have space from the entire ones. We can have space. So this is the option we have, and you can do it. So now one more option is that we have so many things. Yeah, you can see on the screen. This is my safety distance. So it is already 1.5 is there. So I cannot place my implant near to any vital structure. Like example, if I take it down, it will become a red. Like this. So I cannot go it. So this is my safety with the surrounding vital structure. So software is not allowing me. Sometimes I have to take a call if I will go reducing it with 1 mm. Then I am going to the next step. Software is asking once again, you are reducing 1 mm. Are you sure you want to plan this? So this much of safety is software is given to us, like so we can plan it according to our needs. And one more thing we can do, we can see 3-dimensionally. Yeah.
In bypassing case, again it shows the red mark and all.
Yeah, so like there is a 2 options if you want to bypass it. Like even though if you bypass, at least you have to keep 1 mm space. Yeah, so we can keep it. See, I have made it right now 1 mm, and I can bypass it like this. Okay, if I want to take a longer implant, then I can change it over here only. can, like I have like 4 seats. So I can select if I have already planned 4 6, but I don't want now to do a 4 6, so I can delete it also. I can select it and remove it. Like a second. I can plan new one once again also if I want. Now I go to 4 6. Now you can see that I am arranged Bhopal, but I don't have any other option, so I can depend to it takes, I can minimize the candidate. So it's by and one more option we have, like if I click it on 4 6 and I want to parallel with the 4 5, then what I can do is I can click it on a 4 6 and make it align with the 4 5. So both are now parallel, even though I have done a buckle. So now both are at 0 0 degree. And we can check it out the angulations also from here.
How do you check it whether 4 5 is not coming close proximity to the root of 4 4?
Yes, so for that we have this process for my minimum distance. Okay, if it is coming, if you want, you can take it. In this view only you can active 4 5. Yeah, that is also a process. So like this. So whenever you placing it, you have to see 3 dimensions. It is inside of board, it is not touching vital structure, not touching the adjacent implant. You can go like this also. Even vertical height of both implant, whatever you want, you can check it out. And along with that, you can see the gums also, like how it's going. So if you want to select the collar height of the abutment, there is a over here. So you can select the collar height. So all possibilities are there. If I feel that my plan is good and I want to go next, I can go to next. And in this you can see there is a relation between 4 5 forces incline is 0 degree. So both are parallel. If I change the angulation, it will show the deviation. Now Austin have its own guidance system, as I early morning I told you, like, see, there is a X inside, there is a flat wall, so there is a marking on the sleeves. You can see the flat wall. So when you are inserting it, that is also planned. You have the same position, you can stop that. And if most of the time, if we have this kind of single implant also now, we are keeping this flat wall on the buccal side. Why? Because when you are using a transfer coping tumor, no need to rotate inside, just keep it flat wall buccal side and insert it. So very easy to insert, so it will not inflame your nerves and not damage your nerves. Yes, no need to think directly it will go. Even, and one more advantage, if you have a routine angle abutment, if you want to use it, and your angle is from flat wall. So always you have buccal to palatal only you have to go. If you are facing anterior also like this, posterior also maximum and you have to come like this. So it's a common reference. You don't have any other data, you just place flat wall and buccal. Okay, but if you are looking for multi-unit, then you have to keep the angle on the buccal side. Multi-unit have different. We have an angle from the head corners. So for full mouth, you have to little bit.
And this angulation, what you're seeing, the line, is if you're doing an immediate loading of an implant, the abutment is ready, the crown is ready. So you will have to be very sure that when you're torquing your implant, the torque has to come into the same place. Not only your abutment and the crown is going to be in the same position. Otherwise, the pre-made abutment and the crown is not going to sit.
And this is vertical height is already offset. It's called offset. This is this difference between implant crest and see you can see the offset 10.5. It is fixed, so it is there in your drill, guided kit drill, so which is not there in freehand. So like ये 10 mm का हो गया तो आपका 10 mm का drill तो वहाँ नहीं है समझो उसके बाद आप बोर्ड में जाओ. So that's why we cannot use this because minimum 5 mm you require to guide your drill. So 5 mm का आपको उसमें क्या आपका 12-13 mm का drill आता रहेगा. ठीक है तो 5 mm तो उसी में चलेगा तो we are not 8 mm से ज़्यादा बोर्ड में नहीं जा पाएंगे. So this is offset. This is default means it depends on systems. Okay, Austin have default setup. The Stormin have 3 setups. Like you have like which is small, medium, and large. So like that, different system, different protocols.
The add-in the MIS kit has 9.5 millimeters. This is 10.5 millimeters.
Even if you want to do only pilot drilling, you have one more option is like
you can go to open drills. Open guides.
Open guides.
And then you can create your own offset. Depending on the drill, you can create.
Yes, this is your only pilot drill. You can do it, and you can move it how much. And you have to calculate. See now, right now it's like almost 10 mm. So we have used a 10 mm implant. So now you have to 20 mm. You have to use the
drill is the length of the
drill is 20 mm.
So what I understand is that offset is that part which is not drilled.
Yes. That is guided part. In simple way.
From the head.
From the that's from that only we have to guide.
From here your drill starts, not the shank.
So now everything I confirm them, I agree them. The software is generating report that we are used to send to the doctor. He has to approve it, and then we go to the time. So it is very easy to read it and very practical. I will show that once it's question. So like what is your patient name and all, then the index. This is your OPGP of the same case. This is your plan implant. Okay, you can see which size of implant, which company implant you have used it. What is the angulation deviation between two implants? 0 degree. Then minimum distance between safety distance and all are written down over there, which is acceptable range. Everything is there. Then 4, 5. So it has a sections like 0 is center. You can see the blue box. So in the center. Okay, from center we are doing minus this side and plus this side 0.55. So all cross section of implant you can see. So now if you are touching your premolar, you can see over there. You can stop your guide and modify your plan. Okay, even you can see the artery part. So in this you can have a canal also you can see. And you have future crown also on top. You can see gums, crown, everything. So if you are approving this plan, we have a like jump to the guide design. So we have sleeves, so we can increase the thickness. the rounding of this edge. So like while surgery it will not hurt to the patient blood cells. So rounding you can increase it. Then the height, like I want to touch to my gums area, I can increase the height. Okay, if I have distal tooth, I will decrease the height. So my saliva, like coolant will come out. In this I need a rest, so that's why I have to block it.
And also whether you want to do a flap technique or a flapless.
Yes.
If you're doing a flap, you keep the much higher so that when you reflect the flap, then the guide will go sit. If you want flapless, you can drag it till the issue.
And then now the main role of sir is like is going to show you 3D printing. So some like why all printers have different rate because of their accuracy level and easy to work. Okay, some all have some shrinkage factors. Okay, so software and maximum time outer you will get exact, but inner you will not get exact what we have given. This is the most common thing we have noticed. So now companies are starting giving the printer preset. So like they have calculated with the material and they are giving the values. So like now if you can see over here 0, it means the 5 mm का है तो 5 mm ही रहेगा end of the file, ठीक है. But इसमें मैं print करता हूँ तो 4.9 हो गया था inner, तो my drill will not go. Okay, file का design था इसलिए 4.9 हो गया. So now like all printer have their own values. So like I can say accurate. Okay, so now you can see the 40 microns of gap. So like inner part is the software is already making 40 micron extra. So after printing you will get exact file. So this is the good feature they have come up with the after user. So many users have used it and they have come up with this solution. So this is the good thing they have improved in the software. Now I have to select the path of insertion of guide. So here there is this much of extension, so I have to take here because I need a tripodal configuration. Otherwise my guide will dancing over here. So I have to be here so it will move very less. So I have to see all complete path of insertion of here to here. Otherwise straightforward I can take like this. But I have to see anterior also. And so now there is a undercut is like very less. And I will be more precise block out. So now software is blocking out. So like, yeah, so ma'am have a good question. Like there is a different kits. So sleeves is according to the system what you are using it. So Austrian have sleeveless, other has master sleeves, other multiple sleeves, other has spoons.
Diameter of your drill also goes.
Yeah.
See,
So
for example, certain kit has got 5.5 millimeters, certain kits have 4.8 millimeters, certain have 6 millimeters. So based on that, the company will give you sleeves. I have the sleeves. Once the light is there, I'll show you the sleeve. So what we do is when we print it, it will be printed like a hollow like this. That is what Anshul is told about the printer settings. Because see, outer, there is no issues for us. The inner is, if my sleeve is 5.5 millimeters, I need, once I print it, it should be exactly 5.5. It should not be 5.4 or it should not be 5.6. Because if it is 5.4, then it was not going to go inside. If it is 5.6, it will become too loose, and when I'm doing the guided surgery, the sleeves will just pop out.
And if it is not pop out, but if you loop it out, so what happens like there is a deviation looping. So what you inside so that you will go in like this.
The accuracy will be lost.
So I'm marking the extension of the guide.
Okay, you guys want to really understand this, you'll have to come for a 2-day workshop. It is, we are showing, I think, 6 years of learning me, and Anshul we are showing it within half an hour.
Then like this is also, see the engineering learning the dentistry. So अभी गाइड तो बन गया, अभी कोई जरूरत नहीं सीधा प्रिंट कर सकते हैं, पर बोला clinically it is fit or not perfectly, how you can check it out? क्योंकि आपने तो दांत को कवर कर दिया ना, तो अंदर गैप है तो how you check it out? So now they have given the window. Okay, you can.
For the visualization.
Yes. So like this it will give. So it is fitting like this. So like your guide is perfect. So now is like your final guide is ready.
Sir, in limited mouth opening case, do you modify the guide or same sleeve height and all that?
Yeah, that's what in my presentation I told you. Like in that you have to select the system, like which kind of system. If you have sleeveless, you can give a C shape. Okay. Right now, what happen? You have to go like this. But if I give seam shape, so you can go like this and do.
Yeah, there are many implant companies now come out with a buckle opening on your sleeve, so that you know what you have a sleeve like this, which is not from the top, it is from the side. So what you do is you go into the mesial the buckle from the cheek, you enter inside and then go into the drill.
And in that also, what we are learning after doing so much of surgery, for lower we are giving on a buccal side, for upper we are giving palatal side.
It's easier to
go inside and do a surgery. Okay, and along with that, some more modification in the drills, which I told morning I am going to get English. We have a guided area, then some sand are there, and then our physio dispenser and NPC there. So we have reduced that also. So we are only 1 mm in place of 5 mm. So drill also shorter, and you can go buckle in. And one more thing I told you, like you have to go step by step. So like आपने 6 mm you have done it, so after that 8 mm will 6 mm already अंदर चला जाएगा सर. So you have a mouth open, like जैसे अंदर डब में कैसे चला जाएगा. So then you are doing 8 mm. Then you are taking 10, it will go like, then you have, so it will increase your height. So you can compensate. So it will start from 6, then follow by step you have to go. If you directly after 6 you take 10, then you have a lot of problem with the mouth. You will not go inside. So how you have to utilize it when you have your investment. So that's all for the guide.
Export this guide.
Yes.
What's the difference in the planning for the guide if we are doing some, suppose that I am placing strawman, I have to place a strawman but by the dance side drill, right? So I think there will be difference in the planning for making the guide for dance side drill and for companies providing drill conventional drill will be different.
Yes.
There will be 2 different guides.
There is 3 things you can do. One is like completely going with tensile. That is also possible, and that in that you have one spool. So like 2 mm का टाइम ड्रिल उसमें से करके हटा दो फिर सब टेंसा जाएगा गाइडेड. ठीक है. So that is also possible. As such, like you 2 different guides also you can do it.
Strummer has got a spoon. The Strummer has got every drill has got a spoon. So you have to put a spoon and then you do a drill.
And in that like you have common drill. So in that system you will face the problem because your drill is longer. For longer offset also the drill will be same. So
yeah, it's very important that you know what every system has got a different types of surgical kits, and no surgical kit is equal for all. There is no universal kit. Universal kit is only for you know what if you want a 2 mm drill or a 2.8 mm drill, that is where your universal kit will stop. After that, you will have to use the particular. If you, for example, if you are using an X implant system, you will have to mandatorily use the. If you are going for guided, you will have to mandatorily use the guided system of that particular implant system, because there is a lot of other features which are added. It is not just the guide, not the drill placement. It is the size of your implant, the shape of your implant, the taper. So many things varies. So that is why you have to use the same protocol to work with.
Even for protocol for upper is different, for lower is different. Upper you have to do lesser drilling. Lower you can do regular size.
Soft bone protocol, hard bone protocol.
Even your freehand drill have a, if you are doing the 4x10, drilling. So it's at the tip it is 4 mm, like on a breastal area, and down is going to 4.9 or 3.9. But in guided it is 3.5, 3.9 and then 4. It has step drills. Always. Guided. Yes.
Now what is there is Anshul has finished the guide, so he is now exporting it into an STL.
So like I have a STL file over it is saved in my software. So
now we'll put it for print. What we'll do is, now he'll put it on the pen drive for me, then I take it up from here and then we will finish it off. So I'll just very quickly finish it off for print and then we can have discussions. You guys want to have some?
think you're, it's come now. Yeah. Now what we're going to do is, Anshul is already Anshul is now shown us the plan what is done. So now I have copied, he's copied the surgical guide here. You can see this. So this is the surgical guide what Anshul has created. You can see this is a fitting surface and this is a top surface here. Now what we're going to do is, we're going to run the 3D printing software for it. So I need to create a file. Now once we do it, we need to produce it. I told you it's an additive manufacturing. So I have to tell the software that this is how you're going to slice this. So in the 3D printing, it is called as a slicer software. So we need to slice the file to allow the 3D printer to understand. And you know what, even though we have 3D printers in different varieties, the software is unique for each printer. It is not, you know what, we can take a file of one printer to print another printer, it is not going to work. So you should create a file which is specific. So here I am using a printer called as Frozen. It is one of the more economical brand which is there. So I have a software for it called as the Chitu Box. Chitu Box is an open software. So it has got a software. 1 minute, I will just search for Chitu Box. Yeah, Chitu Box is here. So this is the printing software here. Yeah, Chitu Box is an open software, but you need to, you know what, you need to select the printer what you're going to use. So the printer what I have is a Frozen Mighty 4K. So you can see that I have selected Frozen Mighty 4K. So this depends on the plat here. This is called as the build platform. So this is the build platform. You can see this is the big platform which is there. So, and you see this arrow part is the part which is the front of your printer here. So now what I'm going to do is I'm going to bring the file which has already been generated here. I just drag and drop here, and you can see this is what is the file which is being generated by Dr. Anshul. This is the file. So now I need to do it, and what I need to do is, see, it is like building. If I am doing a roofing on top of it, I need scaffolding. If I don't put a scaffolding, it is going to fall down. So I need to print, for example, if I am doing a 3D print, I need to have support on it, and then only the 3D print can occur. So that is what is called as a scaffolding or the supports. We call it as supports. Now when I generate a support, this is the fitting surface. So if I generate the supports on the fitting surface, what's going to happen is, it is going to compromise on the fitting of my guide. So I need to rotate this to do it. So there is a rotate tool here, and I'm going to do is I'm going to rotate it here. So I'm going to rotate here, and then I look into this. So you see this is not, you know, this is going to take a longer time for me to print. So again I rotate here. On a 360 degrees we look into it and we rotate here. I'll make it as flat as possible. Just for the quickness of my printing, I make it as flat as possible. See, this is again a science. 3D printing, everything cannot be printed flat. We think printing flat, everything is going to work. But depends on the shrinkage of the material, depending on the density of the resin what I am using, the curing time what I am using, everything changes. So we need to orient the part in different way. For example, if I am doing a splint, I will keep it at a 45 degree or a 60 degree. If I am keeping a denture base, I will do it. Here, just for the sake of finishing it, I am keeping it at a flat surface. I will not keep a flat surface always. If I have too dense material, like for example, the material is too thick, I will not keep it flat, I will keep it at an angulation. So I get more supports there, and then it is printing and it is supporting at this way. So it is not, the shrinkage is not going to become more on this part of it. Here I am just putting it on a print way, and then I can look it from the top. And always one thing is there, see, one golden rule is, the more economical the printer is, always sit in the center. Right? You know, on your boat, you're traveling in a water and you're not very safe, you're not sure about the boat, you always sit in the center so that it doesn't matter. So in the printer, what happens is the cost of the printer changes You know what, maybe tomorrow I'll talk about it too much. But you know what, when the printer is there, there's something called a light source. Say for example, a very simple example I'll give you is your light curing unit. You buy a light curing unit which is around 3,000 rupees, 4,000 rupees, and you have a light cure which is like Elipar, or you're looking at Blue Face, which is almost 75,000 rupees. What is the difference between a 2,000 rupees light and a 75,000 rupees is the intensity of the light. See, these are also the 600 nanometers, that is also 600 nanometers, but the density what is there gives you, it's different. So that is what is the cost of the printer also changes. So here it is a more economical variety of the printer we will look in. So as far as possible, I would like to keep it in the center. So once I have done it, I need to create the support for it. So I need to create supports here. And then I say, you know what, here what I do is, I'm just going to do, I'm doing an auto support here. And also when I'm doing auto support, I will check. See, these are red surfaces which are seen. See, these are the surfaces which there should be absolutely support should be there. If the support is not there, it is going to fall down. So what I do is, I just want to be a little safer. So I will add some more supports here, wherever those red areas are seen. And always the golden rule is, see, don't think about you're going to waste 0.1 gram of resin more than what I'm doing when I'm putting extra supports, because that gives you more peace of mind, and it says that the support is, you don't have to waste 1 more hour for spending 0.1 ml of resin. Because I've seen people telling, oh Shushankar, there's a lot of resin, why do you waste it? I say, boss, that 1 ml of resin is nothing for you. But if the print fails and if it is going to take another 1.5 hours, then you're wasting more money. So rather than, you put more, but only thing is when you are putting more prints, just see this. See, this is a very important area. See, you don't want the support is like this. See, can you see this? This may affect you. So what you do is you go to that and you say remove. This support, I will remove it. See, I will remove the support there and I will add supports here. And too much supports are also not good, because when you are removing it out, it will be a pain. But here I am going to give you supports here. So once I have developed the supports, you can see this developed support is there. Then I go back here and then I say, okay, now I can see this. See, if you can move this, I can see how my building is going on. See, this is what I told you. Additive manufacturing. See, from here, if you are looking into it, see, this is how it builds. See. Now, okay, I'll go to slice. I will say now I'll create a file for it. I'll say slice. So once I say slice, you can see that I have given everything here. I have given a exposure time of 3.5 seconds per exposure. The bottom exposure is 35 seconds, because base, when you put a concrete, you put a foundation. The foundation is strong, so you put a thicker concrete on that, no? So here also in 3D printing, what we need is we need a complete curing on my base. So that is why we do an extra curing on that part. And as we grow bigger and bigger, we are only doing a surface cure. Because after that, there is a workflow wherein we need to clean the print and then we need to cure it once again in a UV curing chamber. And the light, what is most of the 3D printers are all using is UV light. And UV light is, the most open printers are between 380 nanometers to 404 or 410 nanometers. So you get resin. So everything what you are going to do is based on what printer you are using. See, the type of resin, the type of supports, the type of things, everything has to be tailor-made for that particular thing. So here you can see that here it is showing that it is going to take around 5 ml of resin. It is going to cost me around 26 rupees according to what the cost of the resin is. It is going to take me around 45 minutes or 50 minutes to print this the research. And then I am printing it in a layer of 100 microns is the print which I am doing it. And then I say, okay, I need to file to be generated. I don't want to test my time. I see that you get, this is the print file which is there. So I say, okay. See, now the print file is generated. I can see that in my open folder. The print file is ready now. You can see that it is 2002 submerged surgical guide is my print file. So what I have to do is that, see, if my printer is again in a very good printer, which is more economical, more expensive printers, they are usually connected by LAN. they're connected by LAN or they're connected by internet and things like that. Here I'm using an economical printer which is a frozen printer which does not have a, I cannot control it from here. So what I need to do is I have saved it on my pen drive. I need to take this file, put it onto the printer and then start printing. And when I'm printing, different types of printing, what is the type of printing you are using, based on that is your resin. There are surgical guide resins, there is a split resin, there is a model resin, there is a different resin. So when I'm talking about the theory part of it, I'll explain to you what is the difference between each of these resins. Now I'm going to use a, because here I think my boys have forgotten to pack the surgical guide resin. I have a split resin, so I will use a split resin. So split resin is a clear resin. I would like my surgical guides to be clear, so it's a clear resin which is there. So when I'm going to my printer here, I think you can on the lights here for some time so they can see the. Yeah. So you have this is the workflow when you're looking at a printing setup. That's the printer. Then this is the washing unit. It is in isopropyl alcohol. You need to wash it because what happens is there's a lot of uncured resin which is remaining. So the uncured resin has to be washed out. So you cannot wash it out in water. There are resins which are available for water washable resins today, but may still we rely on IPA, isopropyl alcohol, to wash it out. And once you wash it out, we dry it out and keep it in the UV curing chamber for a particular time. Because everything has got its own bearing. How you wash it, how you cure it, everything has got its own bearing. And this is a 3D printer. When you're talking about a 3D printer, there are two parts in a 3D printer. One is the machine itself, but here this is called the print platform. So this is the area. You saw that area which was there, no, the square parts which is there. So this is the print platform. So my print is somewhere here. So I need to be sure that this print platform has been attached properly onto my printer. And then the next one is called as a vat. We call it as a vat. A vat is a resin tank. A tank or a vat, what we call it as. So this has got a clear film. This is not just a polythene sheet. It's a specific sheet which is called as an FEP sheet. We call it as an FEP sheet. This is a light permeable sheet. So as you go on exposing, it becomes hazy. The more hazy it becomes, you have to throw it up. These sheets are removable sheets which are available. Some companies give you removable sheets. Some companies don't give you. You have to throw the whole vat and buy a new one. So it depends on it. So now what I'm going to do is I'm going to fix this. So I'm going to put this sheet here. And then I connect this. So I can put it here. So this, I tighten it. And this is the resin which I'm using. Usually when you are using the resin, after some time you kept it, you need to shake the resin properly. There are resin mixers. If you, for example, you are using a model resin or a tooth colored resin, you need to shake it properly because the filler particles are all going to get supported down. So you will not get a good quality of it. So it is like this. So what we do is when you open it up, so you see this resin, which is a light permeable box. Usually it's aluminium coated box inside this, or a brown color bottle which is there so that light doesn't hit. Then you pour the resin here. It's a clear resin. And then what we do is I put this pen drive. There's a special place for this pen drive that I put here. Yeah, now we can see that the printing started. So this platform is coming down. This is Z-axis. This is the platform which comes down. So it goes here. But only thing with 3D printing is that when the 3D printing is going on, you cannot visualize anything because it's deep inside the material where the light is focusing. Unless it's a big part, you can work on it. When it comes out, you can see it. Otherwise, surgical guide, this is only this much. So you will not be able to see anything. So we will leave it here. Now this will go on and then it starts moving layer by layer. It goes layer by layer, layer by layer. I have put 100 microns. So every layer is 100 microns which goes into it and it cures. So as I told you, it takes around 45 to 50 minutes it used to be done. And because the light, it's a resin which is going to be cured direct sunlight or direct light, so we usually have an amber colored box like this which is there. So you usually close it. So the whole printing process will start going in there. Yeah, take around 45 minutes now for this to print. So what we're going to do is that as the printing is going on, I think there's a presentation by the byline people, so I give it to them, and then once they finish, they'll come back and we'll discuss more about 3D printing. Yeah, by then if you want, you can just pass on. There's a maxilla which has been printed. You guys want to see the printing, you can just pass it along.
Which we are going to print, you can see on a small screen, which is doing what right now.
Yeah.
We are kind of
Thank you for giving this opportunity to present Bialine product in Scalpel. Bialine basically started its operation in Germany, and because of the facilities available from Israel, they started moving a lot of manufacturing process from Israel. Bialine was started in 2005, and in India we launched it in 2019. Since then we are on the progress path. All our products come with a lifetime guarantee. It has the ISO CE and FDA approval. Bialine uniqueness is that it has all tapered active implant system and comes with biofix surface treatment. Biofix is basically patented surface treatment. If you talk about Bialine product portfolio, it has everything starting from laser compressive 1 piece, 2 piece, and conventional 2 piece to up to zygomatic implants. This is our universal product, which is a spiral implant. This is a grip implant, which basically we use it for immediate extraction sockets where you are taking out a tooth and you want to implant, do immediate implant, immediate loading. We can use this kind of implant. Uniqueness about this implant is it has a very sharp tapered design. Comes with a additional 2 mm of gold, which really helps in avoiding child pathogen development. And this is a one-piece implant, some compressive implant. Pterygoid implants. These pterygoid implants are basically used for only pterygoid region. We have a similar version of implant without any anodized polished surface, which we call it as an eye surface, which you use it for full mouth restoration or treated implantology. And then we have zygomatic implants. We have full restoration options, multiple options like ball abutment, locators, screw retain, cement retain processes, and digital components. Full library of digital components. We also have kits for various use. You can use it for zygomatic and pterygoid. We have a specific kits. Otherwise, the standard kits are also available. We have upcoming course at Dr. R.N. Cooper on cadavers used for pterygoid and zygoma. If anyone is interested, please let us know. And if someone is interested in digital prosthesis or prosthetic solution, to learn implant prosthetic solution, we have another upcoming course in Mumbai, which is again on 15th of January. Thank you.
All these implants are available outside at their counter. If you have any information you want to take, it's available at the counter. So we are closing down for the day. We're calling it a day, and we'll meet again tomorrow. Again, we'll start early tomorrow morning because we have a very long day tomorrow. Again, 9:30. 9:30. We expect everybody to be here by 9:15 a.m. so that we can start our session smoothly by 9:30. Because again, we have 2 more speakers and then these 2 gentlemen here. So total of 4 speakers will be there for tomorrow lectures. So we can start early. We'll be able to finish like by 5:30 p.m. because these people have to catch their respective trains and flights also. So 9:30 we start tomorrow. Okay. The banquet is at those who have registered for the banquet. They have to reach the banquet venue, that is Golden Oak, Shangabad Road, by 7:30. 7:30. So we are keeping it an early banquet. We start early. We finish early. The bus services for people who want to start from here will be at 6:30. 6:45 the bus leaves, and the bus will be back by 10:30, 11. So that is how it will be. Okay? Thank you all. Thank you everyone.
निकाल दूँ पक्का नहीं अब कुछ नहीं क्लोजिंग हो गई मोहित भी को बुलाना